marijuana. My name is Michael Tynan. I'm the policy officer for the State Public Health Division in the Oregon Health Authority. Some of you may be joining us for the first time, so before we go through introductions and hoping that a few more RAC members join us while I go through this, I want to provide some information on the Rules Advisory Committee process and this committee in particular. So convening a Rules Advisory Committee is part of the rulemaking process in Oregon. Administrative rules like the ones we're going to discuss today are adopted by agencies in response to laws that are passed by the legislature. Rules are typically how agencies operationalize the statutes that are adopted by state lawmakers. As I mentioned, the Rules Advisory Committee is an early step in the rulemaking process. Rules Advisory Committees are comprised of community members and parties impacted by the proposed regulations and are convened to provide advice to the agency, in this case the Oregon Health Authority, on the development of the administrative rules. The way this committee has been operating, OHA and the Department of Justice have presented proposed sets of rules, gotten feedback from the committee members during the meeting, and then come back to discuss edits and changes at the next meeting. So today we're going to be doing that first step in that process. We're just going to be going through, getting comments from the committee members, and then at the next meeting we'll bring back the changes that we made. The committee doesn't vote, and the committee is advisory to the agency. Additionally, while the meetings are open to the public, these meetings are not actually public meetings, and therefore participation is limited to committee members only. We have set aside a time at the end of the meeting for public comments, since we believe that constructive public comments and input will aid us and the Rules Advisory Committee in making the most informed rules possible. We've posted a presentation to our website that goes over this in more detail, and can make sure that folks have a link to that if they're interested. Typically, Rules Advisory Committees are seated on an ad hoc basis. So typically, what will happen is the legislature will pass a law, they'll tell OHA or another state agency that we need to develop rules, and we put one RAC together, one Rules Advisory Committee together for that one set of rules. However, in this case, because of the interrelated nature of all the marijuana rules that public health is considering and responsible for, we've just seated one committee. So this committee has been meeting since November. It met weekly through November and the first couple weeks of December, and now we're on a bi-weekly, so every other week schedule. As you'll hear, committee members include members who represent grow sites, processors, dispensaries, medical card holders, laboratories, public health departments, poison control, physicians, academia, members of the public. After we complete the the advisory committee process, the agency will move to make the rules permanent. And we've already done that, for example, on the rules that we discussed in November and December around regulations of medical marijuana grow sites and medical marijuana processors. The next step includes filing notice with the Secretary of State's office and scheduling public hearings. We've got public hearings scheduled, for example, on the rules that I just mentioned later this month, and we'll get you those dates and locations. These public hearings are the formal opportunity for the public to provide comments on the rules. Any changes that are made after the advisory committee process can only be made in response to comments received at public hearings. Now I'm going to go ahead and take roll, it'll take a minute, and ask each member to introduce themselves, since we may have members on the phone, and after that we will review the agenda. So, my list of members. So, John Bays. Good timing.
My name's John Bays, and I'm a Green Voting Campus.
Great. Robert Blake. Not sure if I was going to call in. Dr. Greg Blashy. Les Helgeson. Rob Hendrickson will not be here. He's stuck on the East Coast. Mobley Holmes. Here. Timothy Janet is available to join us today. Debbie Kaufman.
There.
And Debbie, you say you represent, sorry.
Debbie Kaufman, Portland State University School of Community Health.
Great. Paul Lewis. Deanne Mansfeld.
Deanne Mansfeld, Union County Public Health Department.
Great. Amy Margolis.
Amy Margolis, Emerge Law, and the Oregon Cannabis Association.
Great. Dave McNichol.
David McNichol, Dave Space Cakes, and the chair of OREC.
Great. Jeremy Sackett. Cheryl Smith.
Cheryl Smith, Advisory Committee on Medical Marijuana and Compassionate Oregon.
Great. Scott Winkles. Okay, so we've got several members who are absent that will join us through the meeting. So Shannon, you want to introduce yourself?
Shannon O'Fallon with the Oregon Department of Justice.
Great. And then Rosa Klein, who's our legislative coordinator, will probably be joining us as well. So today we're going to be, oh, I'm sorry, and Sunny, are you with us as well on the phone? ODA?
I am.
Great. So can you tell us who you are? Since I know who you are, but other.
Buddy Jones, Cannabis Policy Coordinator, Department of Agriculture.
Great. So today what we're going to do is we're going to go through serving size and concentration limits. And so we've got a packet of information that we can talk about in a second. We thought that we'd first have a discussion around serving size for retail products, then take a break, discuss serving size and concentration for medical products. And Cheryl Smith has a document that she gave me that we're making copies of that'll be available after the break. I see Paul's here. And then after that, we'll talk about the future meeting schedule. We'll identify sort of what we need to, depending on how far we make it today, what the next meeting looks like, which is currently scheduled for the 25th. Any questions? Great. So I thought the way that we could do this is we gave you a packet. In the packet, there is just the temporary rules that OHA issued in November. That's a 2-page document. So page 1 and 2, section 333-007-0200. You've got 2 tables, table 1 and table 2. And then there was an additional handout that is just the sort of the overall section 333 definitions that we wanted to make sure people had in case those come up. Because, for example, that's where tinctures apply. And as I mentioned at our meeting in December, we've already identified that there's some broad definitions that we need to adjust. We need to expand the definition of tincture to include more products than it includes now. We need to discuss creating a category for capsules, especially on the medical side. It was not our intention that capsules be captured under edibles, but that they be captured elsewhere. If we don't, and that's not clear or obvious, we need to discuss that. Are there any major issues that you remember? Okay, all right. And then just talking about sort of adjusting serving size to be a little, just in general, as committee members wanted to. So Paul, do you want to go ahead and introduce yourself?
Yeah. Paul Lewis, Multnomah County Health Officer.
Great, thanks, Paul. Great, super. So I'm going to turn it over to Shannon.
Okay. So I'm just going to walk through the rules, and then we'll start taking comments from there. So I'm starting with 333-007-0200. Subsection 1 is just sort of a restatement of the statutory authority and the statutory direction for the Oregon Health Authority. So the Oregon Health Authority is setting concentration limits and serving sizes for both the medical and the retail side. And specifically the statute, House Bill 3400, says that OHA is supposed to set serving sizes for cannabinoid products, concentrates, and extracts, and then the number of servings per package, which would give you sort of a maximum concentration limit. And I think it is, again, important for folks to understand that the legislature has required the Oregon Health Authority to set concentration limits, not just for edibles, but for concentrates and extracts as well. Subsection 2 of 0200 is meant to get at an issue of levels of THCA that may be in a product, and it's unfortunate that Jeremy and Mallory aren't here.
So this is walking in.
Oh, great. Since I barely understand this. So my understanding is you can have a product that is high in THCA, and then that gets activated to THC, which when heated. So if you had a product that had high levels of THCA that were meant to be heated, the THC would then get activated and be psychoactive. So you could have a product that I guess if you weren't, so the THCA on the label is supposed to tell you what the THC levels are going to be if the THCA becomes converted to THC. Okay, so that's what this subsection 2 is meant to get at. Subsection 3 is sort of a disclaimer that, you know, the actual levels of THC in a product, you know, it's not every product that's packaged for sale that's going to be tested for THC. It's a, you know, representative sample for products that are going to be taken. So you could have a THC level in a particular product that is not exactly what it says on the label. That's what subsection 3 is meant to get at. Subsection 4 is sort of the effective date of the rule. So in April, starting in April, any product that is transferred to or from medical marijuana dispensary, or once we have OLCC retailers have to meet the concentration and serving size limits set with these rules. So there's going to be a little bit of leeway here before those rules go into effect.
Sorry, Liz.
Government for you. Yeah. All right, subsection 6 says that if you have something that falls within the category of an edible, it has to meet the concentration limits of edibles. Though note that the definition of edible does not include a cannabinoid tincture, so you have to make sure you go back and look at the definitions. There's a different definition of scorable that is important, because products that are scorable or not scorable have different serving size and concentration limits. So if you have a product that is solid at room temperature, it's scorable if you can physically demark it. That enables a reasonable person to understand what a serving size is and to actually separate then serving sizes. So, you know, the product that's the easiest to refer to here is you have something that looks like a Hershey's chocolate bar, you know, that has sort of those sections marked in it. So that's what's scorable. All right, so 0 to 10 is the rule that refers to retail concentration and serving size limits, and so you need to look at that rule in combination with Table 1. You should all have Table 1. So the serving sizes and concentration limits are set out in the table. So for edibles on the retail side, you can't have more than 5 milligrams of THC as proposed, not more than 5 milligrams of THC per serving, and not more than 50 milligrams in a container. If you have a cannabinoid edible that's not scorable, so a liquid, for example, it's still 5 milligrams per serving, but you can't have more than 2 servings in a package, for a total of 10 milligrams. And then for topicals, it's a 2% concentration limit per package. For a tincture, the container size is 1 ounce.
Folks,
You can have up to 250 milligrams of THC in that product. For concentrates and extracts, it's a maximum container amount of THC of up to 250 milligrams. And then for a cannabinoid product that's not an edible or a topical, it doesn't fall into any of the other categories. Again, it's a 100 milligram THC limit.
can you remind us what that would be?
It really, I don't know what it would be, but there's a lot of creativity in this industry, so we're just trying to make sure that there's sort of a catch-all. So I don't actually know what would fall into that category.
Well, I mean, I think that's what we want to discuss today. So is there a category? Well, I mean, it's 2 questions. One is there a category specifically for products like capsules, suppositories, patches? And then a secondary discussion of that is, do those even belong on the retail side? Do those only belong on the medical side? Would be so it's sort of a 2-part discussion. But I think which would potentially remove the need for these not edible or topical category perhaps. Because then at that point, if a new product shows up on the market, then we kick off the rules advisory committee process. We could potentially create it so that products that don't fit into any of the categories that we've described so far are not allowed to be sold unless, not that I want to become, the state version of the Food and Drug Administration, but until some sort of approved regulatory process is engaged in.
So one other thing to note is that for non-scorable cannabinoid edibles, they're supposed to be sold with a measuring device that allows you to measure what a single serving is, or be placed in a package that easily allows you to tell that there's more than one serving. So, a bottle with a mark halfway if there's 2 servings, for example, if it were a liquid. So that's important as well. The other thing I wanted to bring to your attention is there should be sort of a table in your packet. It's a state table that sets out serving sizes and concentration limits for Washington and Colorado and Alaska. So it looks like this. It says state table for concentration limits and serving sizes, just sort of as a reference document for folks. So I think we're talking about.
I think it needs to be pointed out that the table's incomplete. It doesn't include Washington 105.
Right, but that's a packaging. That's a packaging. I don't think it changes what's on here, but we can talk about that. Yeah. Okay. So I'm going to stop there, I guess, and we'll open it up for comments or questions. Scott?
Scott Winkles. Under cannabinoid concentrator extract, you have an up to 250 milligrams per container. Could you sell a single serving soda, marijuana soda with 250 milligrams of THC in it under this?
Well, that would be an edible.
Okay.
It would be an edible, not a concentrator extract.
Okay, so this is a standalone concentrator.
It would be a non-scorable edible.
Okay.
So as Shannon mentioned, the maximum that a liquid, under these rules, the maximum that a liquid could be sold on the retail side would be 10 milligrams. If there was a way that a user could demark that this is what a single serving would be.
Okay.
So you could have
beverage.
a liquid beverage, correct.
Okay. Perfect. Thank you.
And that's distinctive from a tincture, which is up to a fluid ounce and up to 250 milligrams. Which we've heard from, I guess now's the best time to bring it up as any. We've heard from manufacturers of tinctures and cannabinoid extracts, concentrates and extracts, that 500 milligrams may be a more appropriate level for, they'd like higher, but 500 milligrams may be a more appropriate level than 250 milligrams because these products are typically sold in a gram or a half gram. So that's something we've heard. I don't think we've made a decision on what we're going to do, but that's feedback that we've heard from the industry.
Also, this is John Greenbody. My main concern about this part is like vape pens, So we're trying to mitigate some type of excess consumer product made from China trip. I think, everyone in this whole thing. And when we start to drop the milligram dosages of THC to such a level where normal vape pens on a, kind of somewhat waste-oriented situation, you want more in the pen, So most of them are putting a gram in it, and a gram ranges at anywhere from 60% to 95% cannabinoids. So that range can vary on all levels, So if then they're say, okay, you're only allowed to put 250 milligrams in there, then you drop it and everything doubles, the waste doubles, the excess. It just starts to get very, from my perspective, consumer driven with the people making the profit, not necessarily Oregon, like China, stuff like that. So I'm kind of like, this is a huge, out of all of this, what I see, this and the tincture concentration on, say, a concentrated tincture, are my two big concerns. So I'm kind of, we can mitigate this pretty well. We've already talked about how we're going to work it out and adding CBD and adding these other aspects, and if this says THC, if we're putting THCA in this, and that's not something that's going to be controlled under this, then it starts to there's a lot of gray area in it, and the vape companies will be able to do whatever they got to do, I'm sure, because most of the product in there is actually THCA. So a lot of it's not been decarboxylated, so it gets in there. So I just want more clarity on that, so everyone in these big avenues of business that are like going to be our largest vein of this industry when it goes into rec, from my perspective, vape pens and stuff, we should try to think about what we're doing ecologically in that process.
So, yeah, I think that's helpful to hear. I think we've got a lot to talk about today, and I don't know the best way to structure sort of the discussion. So I don't know if because there's a lot of different, and I'm saying it's helpful because there's a whole other sort of host of products other than edibles. And so we were just sort of talking about edibles and hadn't gotten to, and so like, as we talk, so Shannon and I just finished sort of going over the big picture. Is the best way to do this to sort of go through the table, or like go around and get feedback from members? Like, how do you guys want to handle this? I think, I mean, because otherwise, I want to avoid jumping around from product type to product type.
Table orientation sounds good.
Yeah. Okay, Amy, go ahead.
Before we get to going through the table, what would be helpful for me, and I think what you handed out for the Retail Marijuana Scientific Advisory Committee, is I would like a more talks of the trees conversation. Like, we decided to have a reduced dosage, or however you all decided to, what brought us to this place, have a conceptual conversation about those conclusions, and then work our way down from that conceptual conversation into the individual products. Because I look at this Scientific Advisory Committee public meeting minutes, and I see what the objectives were. And so I don't know if that's the conceptual starting place, or the conclusions reached during those meetings are the conceptual starting place, but it would be helpful for me to understand the drivers behind these decisions.
Okay, so I mean, I think, and I'll try to paraphrase as best I can, because it's been, I mean, it was almost a year ago that this happened, but the Science Advisory Committee, this was the first meeting of the Scientific Advisory Committee, and there was significant participation from Colorado at that meeting, and sort of learning and hearing from the Colorado experience. And the discussion sort of quickly moved to, we can either do what Colorado and Washington have done, and do, you know, a 10 milligram serving size with, you know, up to a package size of 100 milligrams, realizing that Washington also has this sort of, when you have more than one serving, it has to be individually sort of contained. Or we can sort of take a more cautious approach for recreational users, and sort of they have it, and so it was, and that was sort of the prevailing recommendation from the committee, and it came primarily from sort of the discussion that was led by, and Katrina, you can jump in here if I mischaracterize anything, but it was primarily led by sort of the recommendations, guidance of the Colorado Department of Public Health, who sort of said, if we could do it again, this is how we sort of wish things were done. And so that's, I mean, I don't know if that's enough of an overview, but that's sort of how I recall that meeting going.
And was that a data-driven conclusion from Colorado, or was that like a kind of hearts and minds conclusion? I looked at I'm not a doctor or a scientist, but I read the information provided in these cannabis poisoning in children and coma due to cannabis toxicity, this packet that was provided. So, I mean, I meant to come actually prepared with my own data.
Right.
I'm just too goddamn tired. So I didn't. But it seems to me that it doesn't feel like that's really data driven. That's a kind of, I wish I did this, but not because 5,000 children, God forbid, ingested cannabis. So where did that decision come from? I just didn't participate in these meetings. So was it because they just felt it, or because they had this, you know, voluminous increase in overdoses? I don't like to use that term with cannabis, but I'm going to use it for this context.
So what I recall, and I don't know, Katrina, do you want to join us up here, or, I mean, sorry, so Katrina Hedberg is our state health officer, state epidemiologist. She ran these meetings.
There's the one broken chair.
I got it right here.
So
the discussion we had at the Retail Science Advisory, and it is specific to retail, not to the medical market, so we say that, but the folks from Colorado actually have had, it was based on data, it was both some of the hospitalizations that they'd seen in kids who had ingested very large amounts of, for example, edibles, brownies, etc., and the increase in number of calls that they had gotten to poison control based on ingestion. And it was also that, particularly in young kids, some of the consequences are pretty severe. Some of the kids get very somnolent, stop breathing, and that kind of thing. So it really, again, thinking about this not for the medical, but for the retail market, what would what would make most sense? So it was not just anecdote, it was based on data from the folks in Colorado.
So what was that? I'm gonna get there, just give me a second. We're gonna work our way there. So what was that data? Is that somewhere in these packets? Because I didn't see it, I just saw the article.
Yeah, so we can get that. I mean, it was calls to poison control centers in Colorado. It was not handed out. So what has been handed out in the packets, of course, is from peer-reviewed literature, but there have also been some articles written in the MMWR, the CDC publication, about some of these severe reactions that people in Colorado had had after ingesting very large amounts of edibles, primarily.
To me, and somebody else should step in if you have something you want to say, but to me it would be, and the reason I wanted to start at this kind of this tops of the trees place is because to me it seems like, for at least for me, it would be helpful to know what that data is. I mean, I asked the internet that question at our last meeting. I brought up the statistics I was able to find on the internet, but to me, it seemed that those numbers were, in comparison with very many other things, extremely low. So it feels like it's challenging for me, at least, to have a conversation about these decision points when I don't know the data they're derived from. So is there some way that you can provide us the information that we're making these decisions based on?
I have to imagine everyone's in agreement with that. So make some blanket statements on kind of conclusive evidence. We're talking science on national, medical changes. I think we should really mitigate uncertainty so we have all the information, we can at least make the right decisions.
So what was the science that 10 and 100 came from in Washington and Colorado was one of the questions that we asked, and we weren't able to find an answer to that either. And so I think that was the challenge that we were dealt with when we were preparing for the first scientific advisory committee meeting, is we spent a significant amount of time trying to identify where 10 and 100 came from. And we were never able to identify a science-based rationale for that number either.
Paul Lewis, Multnomah County Health Officer. I think an important concept, given where we are with legalized recreational marijuana, is that there's not enough information to make a rigidly scientifically based determination. And so the public health pivot when that happens is to use what we call the precautionary principle. So when we don't have certainty, and in this case it's impossible to have certainty, that we pick the most cautious approach and agree to revisit things as more information becomes available in the future. So as I've said before, I'm going to continue to advocate for, let's take it slow, let's make it smooth and successful for everybody involved.
I had wondered, this is Cheryl Smith, about was there an educational program in place in Colorado, and then has one been implemented since? Because I think you'd see those numbers going down. It's something that's been sorely lacking here. We've had medical marijuana for, what, 20 years or something, but yet there's never been, the state's never felt compelled to start educating on this so we can avoid these overdoses by children and pets. So that, that's what I would want to look at too. Is that part of the problem? Is that there's still this verboten thing. I know, and some of the problems that come up with these kids overdosing is that the parents are afraid to say anything, so the kids end up with these horrible interventions, lumbar punctures, ventilators, because they're trying to figure out what the hell's going on with the kid. or if there was some kind of educational program and maybe a no harm to the parents by disclosing, then perhaps we could resolve some of the problems too.
Especially when this, I mean, it's so widespread right now in Oregon, we have to inform everyone really well. I don't understand why there's not a program really being set forth in the education system where we think, hey, teach the kids what's going on, we have the information, awareness, so we can really mitigate all this stuff in our state and show like what we've been trying to do.
Can you speak up so we can hear you in the back, please?
This entire time since 3460 is to try to set an example.
Go closer to the mic.
We didn't want to be like,
Can't hear anything.
we didn't want to be like Colorado. We didn't want to be like Washington. We wanted to do something better that showed that we saw awarely what was going on in these other states and we did something better. So I mean, really setting forth these proper education information programs is really important, in my opinion.
Hello, Julie Jacket. I like that we're having a healthy discussion here and looking for some data to actually base some of these decisions and policy on. With what Paul mentioned, I think that we have an ongoing kind of review of this data, and there has been some good information presented. I did want to just draw, and kind of building on what Cheryl commented with education pieces, that some of the data that has been presented, at least to the group here, pediatric marijuana exposures in a medical marijuana state, this research article here, it does show that there is an increase in incidence, I guess, to keep it simple. But in the discussion and in the conclusion, quote unquote, currently there are no regulations on storing medical marijuana products in child-resistant containers, including labels with warnings or precautions, or providing counseling on safe storage practices. The data are from Colorado, and medical marijuana state laws vary, so our findings may not apply to other states. Essentially, this data that shows increased exposures is being drawn off of a state that did not have any additional regulations for packaging controls or labeling controls. I think that's an important point to make as we're looking at these increased exposure levels, as well as the exposures that are occurring. Some of the other pieces of literature indicate that there was no, essentially reoccurring, everybody was released in less than 48 hours. All of the symptoms were alleviated. I've dug through with some detail in these, and I would like to see additional data to support the 550, and also continue looking at the 10-100 or any other combination that would be most appropriate based on the data that we should continue to evaluate, and have additional packaging, labeling, and other child-resistant controls in place.
I'd like to add, I'd like to see the exact same collection of data, and I'd also like to see it in a sort of comparison to other both controlled substances and non-controlled substances. To me, the conversation is not just this is a fear or a concern, so we are going to hyper-regulate it. I think that there are so many people here today, and there are a lot of people here today, because they are concerned about a few things, and they can articulate this for themselves, but this is effectively going to, at worst, kill the market, and at best, significantly stifle the market. And I think it's important to recognize
we have a lot to cover today. I'm going to ask everybody please not to applaud and just let us have our meeting. And there will be an opportunity for public comment at the end. Amy,
It's
go ahead.
our meeting. It's a public meeting.
The meeting's going to end at noon today. And if we don't have an opportunity to go through all the public comment, the meeting will be over at noon because we have other meetings we have to go to. Amy, please go ahead.
Thanks. And the follow-up to that is that Oregon has had what I call a relatively unregulated market in terms of edibles and tinctures and concentrates. And what we haven't seen from that is a public health crisis. So, I mean, we've had licensed dispensaries here for quite a while, and this is, I'm guessing, but if we had a public health crisis around children ingesting accidentally cannabis and finding themselves in the hospital, or poison control being called, we would see that. I mean, that's the kind of thing that makes news, and I So I'm just concerned about balancing the needs of a successful market against what is a perceived and potential public health risk that has never really come to fruition. And that, again, that's why I want to have this conceptual conversation, because I do think we need more data. I do think we need more information. I'd like to see it compared to, like I said, other controlled and non-controlled substances, but walking backwards away from what has worked relatively well in other states doesn't seem to be the right answer to me.
I totally agree with that.
Speak up, please.
I'll play on my condition of charity. Is it possible to get some information about concentrations that are currently in dispensaries? I think John, Bob, and other dispensary owners could maybe help us out there. What, for example, with edibles, what is the content, the average content in those edibles and concentrates that we have in existence now?
Huge range.
It's a huge range, and for us personally, we don't really supply a lot of those products because we can't control the precision. That's our perspective on it, and that's why we, many reasons why we're vertically integrated in that reality. It's such a wide range, and the quality control of these people making them. I know a lot of people making edibles. I don't really agree with most of their practices. That's just my own personal perspective. So the trust that it's all labeled correctly, homogenized correctly, all this, it's kind of tough for me. So I mean, that's my real perspective on it. And to see, like, you look all over the state, there's anywhere from 5 to 2,000 milligram serving sizes, so I mean, when I've eaten 1,000 milligrams or 500 milligrams, I feel like I'm having a stroke, so I then have to do deep meditation to control my heart rate and blood pressure, so I don't so I understand this reality is a huge problem.
You're not a patient.
It would be helpful to have some idea of what's on the market now. There's absolutely nothing in here about that. I'm not saying we can get it precisely, but it would be nice to compare with where we're at today with where we're going to try to go with this.
Unlike John, our dispensary has I can't say because I haven't been to John's dispensary, so I'll say what we have. It's a wide range. Because we have our own lab where we make capsules, extracts, vapes, everything, and we do it in a very scientific and hopefully well-tested way. To have a 200 or 300 milligram capsule the size of a small Advil, it's there all day. But it might have 180 grams of CBD and only 100 grams of THC. Who takes those? Patients. The thing that's missing from this whole equation is that the therapeutic dose for somebody with cancer or epilepsy or other diseases are way over a gram a day. And the science is not there, particularly from the medical community. And I've worked in the healthcare community for 30 years. And doctors, half my clients don't even know what a cannabinoid is. So we're in Oregon, we probably know what it is. But go to other places around the country, they don't. But I'm saying the therapeutic dose for medical, my bench for any serious disease is 500 milligrams a day, and it could be almost all THC.
Minimum 500 milligrams.
Minimum, you're right.
You know what I mean? Some are taking quite a bit
So
of
I think we've got an
We
opportunity.
need to talk about medical after the break. I think
Okay.
what we wanted to try to do was and I know it's hard to disaggregate them, but it's also, it complicates things if we talk about them at the same time.
I understand, Mike.
So, I mean, trust me, we've been struggling with this for a while. Okay, yeah, okay, got it.
So we're focusing on recreational.
For right now.
Right now.
For right now, until the break.
Okay.
Outlet.
Is this the last time we're going to talk about serving sizes?
It depends, we'll figure that out at the end of today. I mean, I think we've got next meeting scheduled discussion at 11:40. I think we've got to figure out, it depends on how far we make it today.
All right. So can we just dive into the details about the edibles and the different categories of the retail side?
Let me say, I think it's unpractical. I do not think it's likely that this is the last time we will talk about it.
Okay. So
I think it's very unlikely.
So I understand that the other committee has repeatedly recommended 5 and 50. I just want to talk about one really clear contradiction here for me. Just looking at the edibles, leaving aside the mystery category and the concentrates category and the topicals. So there's 3 edible categories. There's scorable, non-scorable, and then there's tincture, which is an edible category. So the thing that worries me here is that first the decision was made for 550. And then, and that was aggressive, right, in terms of public safety. It's much more conservative than the other states have taken. And without addressing whether or not that makes sense, then all this other stuff flowed from that. So, scorable edibles are 550. Non-scorable edibles are 510. And then a cannabinoid tincture is up to 250 milligrams. So what that means is that if you have a soda, which is a cannabis product that you drink, you can only have 10 milligrams in it. But if you have a tincture, which is a cannabis product it's a liquid that you ingest orally, you can have up to 250. So that doesn't make any sense to me. And it's not on the tincture side that it doesn't make sense, it's really on the other side. So 5 and 10, I mean, doing that and making it not 40 or 50, again, I understand the rationale, but basing it on the super conservative 5 milligram single size dose just doesn't make any sense. And in comparison to the tincture, it just makes the whole thing seem to lack any logical structure. And I think that's another aspect of what Amy was getting at. Like, what's the logical structure behind how these things are related to each other?
Can I ask a follow-up question? I mean, I hate spinning my wheels on these things. Are we going to change your mind? And if that is a possibility, what kind of information can we as an industry provide you to make that happen? So, I mean, I think we've kind of exhausted the idea that we feel like this is an overreaction to an unreal public health crisis, but I don't think you need to hear us keep saying that. And so I want to know what we can do. What information can we provide you? What kind of data can we provide you? What kind of anecdotal information can we provide you to change this? And if there is no chance of changing it, I think we'd like to know that too.
I think, yes, we're talking about change. I think that's what we're having a discussion about today. So this is not set in our minds one way or another. So what we did, which is not traditional, is before we put out these temporary rules, we put them out for public comment. And that's not something you typically do for temporary rules. Traditionally, temporary rules, the agency just issues them, and there's no sort of public comment period. And so we put them out for a couple of weeks, two or three weeks, I guess, and we got public comment. And we heard basically from 2 distinctive sides. We didn't make anybody happy, right? And so we heard from what basically a sort of a redo of what we just discussed, which is how the heck did you come to 550? Why 550? It needs to be much higher. To the other side, which was from the public health community, which was it needs to be single serving size. There's no reason for there to be multiple doses of THC in a package. It needs to be a single dose of 5 or 10 milligrams of THC. And so it's sort of, we sort of didn't know what we did at that point. Like we sort of made no one happy. And so that's the point of the Rules Advisory Committee, to give us input on what's the right approach. And so I mean, at the end of the day, is it possible that we are exactly where we are? Yes, it is. At the end of the day, is it possible that it could be the same as Colorado and Washington? Yes, it is. Is it possible at the end of the day that it could be 5 milligrams, 10 milligrams? Yes, it is. I think there's a spectrum. And I don't know where we're going to end.
So I think part two of that question is, what kind, I mean, I'm sure our feelings are important to you and our thoughts are important to you, and I appreciate you hearing us. So I think the next question is, what are you looking for from us to, I mean, I of course have a very clear perspective on this, so I'm interested in how to push towards the way I perceive the school should be made, but what can we provide you? What are you looking for other than our thoughts and feelings?
Well, I mean, I think we want to have a rationale on why people want to change something. So just saying, and what it should be, right? And so just saying it needs to be 5 and 50, or it needs to be 10, 100 because that's what Washington and Colorado are doing isn't good enough, I think, for us. I think we would like a rationale on why it needs to be 10, 100, or why it needs to be 5 and 10 with a single serving or a double serving per package. That, either end of the spectrum, we'd like to hear a rationale for that. Was there another part to your question? So I think the other thing is, you know, I mean, this isn't a, we wrestled with this for quite a bit. I mean, trying to figure out what the right answer is. But we, you know, we're not an economic agency. We're the public health division. The legislature gave a health agency the responsibility for doing labeling, serving size, and testing standards to protect the population's health. And that's the goal and the lens that my bosses and my colleagues are going to apply on this. So I think that's always going to come into play. And so it's unfortunate that Dr. Hendrickson from the Poison Control Center is not here today, because he's the one who distributed the materials that we've got on the exposure papers. Sort of examples of what we've heard. We've heard, I mean, soon after we closed the public comment period on the temporary rules, we heard from people that we got the tincture definition wrong. And it was just an inappropriate definition. It didn't capture all of the classes and categories that are out there. We're willing to change that. We heard that that for tinctures and extracts that the market typically sells gram or half gram doses, and so or serving sizes. And so is a half gram more appropriate on the retail side, and a gram or larger more appropriate on the medical side? I think those are things that we've heard because of sort of market examples. And so examples like that would be helpful as well. So I don't know if I answered your question or...
No, I think you answered my question, and I appreciate your thoughtful response. So for me, I think you're right to, not that you need my approval, but to divide it up in terms of, this is a medical conversation, what do we need to provide the medical market, and what do we need to provide the recreational market, and to address those a little bit differently, although from a public health perspective, you're still talking about access, right, minor access, and that's where things like packaging and block containers and education come in. So I would ask that we, and it doesn't sound like you're going to stop talking about this issue with the Rules Advisory Committee today, but that we have this conversation today, that you give us an opportunity to kind of meaningfully gather information, bring that back to another meeting, and then have a really data-driven conversation, or recognize that there's simply not enough data and everyone is just guessing. So that would be most helpful process-wise to me.
And it may be that we're in a different stage of grief right now, but we've already sort of accepted that there's not the data out there that we would like. I mean, that there's not, I mean, that where we started when we met with the Science Advisory Committee is I asked the question of what is the level of, what amount of THC will put a kid into the hospital? If my 5-year-old accidentally ingests an edible product, what's the amount that put them in the ER? What's the amount that put them in the ICU? What's the amount that will get them intubated? And we didn't have that information. We didn't have that information at the time. We asked Poison Control, and they didn't have it. Now we actually do have some of that data. And from what Rob Hendrickson's given us, it looks like it's a number between 30 and 50 milligrams based on the weight of the child.
And so it seems to me that's like almost the wrong question.
Okay.
So that's not the data I'm necessarily looking for, because there are many things that a child can, and this is such a complicated conversation, but there are many things like diaper rash cream, and I use dishwashing pods. Like, there are many everyday life things that a child can ingest and that children do ingest, it appears, on a more regular level that we don't hyper-regulate. So that's why this conversation to me is so complex, and I appreciate that you're willing to have it at
Yeah.
this stage.
And the additional layer to that, and then I'll let RAC members weigh in. And I just want folks to understand, like, when we are sort of discussing, like, what are we going to do? You're right, there are other products that are harmful and potentially poisonous to kids. They aren't typically baked in a cookie or contained in a chocolate bar. And so that's the challenge that we're dealing with, is that other than the pod example that you gave, which is colorful and attractive to kids, medicine is not typically contained in a chocolate bar or a cookie or a cake or something that a kid actually wants to eat or could confuse for a cookie or a cake or a chocolate. And so that's the challenge from the public health perspective that we deal with.
Well, and I'm not, somebody else, not my phone wants to talk.
Yeah, me too, I don't want to talk.
So, I have a few things. One, I like Mowgli's term, the mystery category for rec. A 100 milligram item that we don't know what I don't, on the retail side, the recreational retail side. I think I have some.
A suppository, there's an example.
If that's recreational, okay, but. I have a hard time, but it's not defined. But seriously, folks, it's not defined, and I have a hard time with this category. I really don't know what it is. We're going to throw it at 100 milligram level. So if we have something more signed words or something along those lines.
And I don't know if I said this before you came in, but I think we're considering creating a category for capsules, suppository, dermal patches that we think would then sort of cover this. We could strike this category from even existing and create some sort of rule that only products that meet within these edible, topical, tincture, concentrate, and then high-dose products, or whatever we call it, category exist. And then we have a larger discussion about, do those high-dose product categories even exist on the recreational side? Do they only exist on the medical side? So I don't know if I said that before you came in.
Address the current and secondly, we heard the state epidemiologist, listen to Dr. Lewis, and I think there is a sound rationale for these 550 caps. I know there's not the data to support them. There's not the data to say increasing them is safe, but we do have certain clues that things we need to investigate more. So I have seen reports from Colorado that are not complete and may not be well done, but bear further investigation on marijuana traffic-related fatalities. Coming out of Washington, we know we've had instances in Oregon as well. Again, we walk before we run. I think this precautionary approach is in the public safety's best interest, and we would support that moving forward.
Also, I mean, we are very focused, this is recreational, but there is nothing medicinal about recreational from a safe point of view.
Correct.
So this is, I mean, we're talking about what's the normal dose for someone to become, recreationally high. All of this fits. I mean, if we can throw logic into this and make it really fit well, that'd be awesome. So the reality, though, I mean, just moving forward to get through this, get to the real meat, where we all really care about the medicinal aspect of this thing. So,
Paul and then Les.
Yeah, I think I want to, again, pick up on what Molly said. I had the same concern just because I didn't really understand the tincture, but then whatever someone just said about cake and candy, I think, that's my pretty transparent standpoint. I'm not necessarily concerned about the 250 if it's not in a form that's inherently attractive to preschool age children, right? I mean, if it's I'm imagining like a nasty tasting alcohol or something that you then dilute for use that again a child would spit out, as opposed to a chocolate or a brownie or something like that they would eagerly consume and then not stop at a single serving. So again, I think there's a way to tie this together from my standpoint with either more carefully defining the tincture in that in the sense that it's not something that's just going to be consumed completely by a preschool age child.
And are we stuck on that 250 milligram dosage then for that tincture that's not going to be consumed?
That's what I said. We received feedback after our public comment period closed that a more appropriate number would probably be 500 milligrams for tinctures and concentrates. And so,
I have a question on how, if you ingest the tincture, what's the time frame you would become intoxicated, inebriated, or feel the recreational effects?
For me, on a personal level, and I have an extremely high tolerance of THC and other cannabinoids. For me, I can take a high concentrated tincture that I decarboxylate in the process I do, and I can feel the effects within 3 minutes if I put it under my tongue sublingually. Then the full effect ranges all the way up to 90 minutes, where, you know, personally, if I take 100 milligrams to my head like that, I'm getting minor tactile psychedelia and stuff like that from that dose that I deal with. You know? But some people.
The longer it takes, I get concerned about the stuff that takes 90 an hour.
less.
Thank you. I won't weigh in specifically on the 5 and 50. Need some more data. I think the thing that's giving me a bit of heartburn is the division into scorable and non-scorable. When I raised a couple of kids, I don't think they're going to distinguish between the scorable candy or unscorable. You know, that's the one that's really off the charts for me, the 5 and 10.
So the point of the scorable and the non-scorable was we wanted to set it up so that users knew how much, when you look at it, how much a single serving was. So if a product, so that the rationale with the non-scorable category was if you had a product type that couldn't be scored, then it's easy, you can cut things in half, sort of by your eye. But it's a lot harder to cut things in tenths, for example. And so that was the rationale, was thinking that, you know, you have something that would not be scorable, for example, would be ice cream. Ice cream's not scorable because you can't score it at room temperature because it's on your countertop. So that was the rationale with the non-scorable, was it to be liquid and semi-soft items that are, it's not that there would be a scorable or a non-scorable candy bar, although those could exist. Someone could choose not to score the candy bar and then they would only be able to have 10 milligrams in it on the retail side. It was to get to this other class of products that were sort of soft.
Well, I hear you. I think the concern I've heard is the pediatric side of things to this. I mean, presumably adults can read the label. The label will have a number of serving sizes, total amount of THC and so forth. So I think we should give the benefit of the doubt to the consumer that they'll be able to understand that and not eat the entire candy bar. Now, in the case of pediatrics or 5-year-olds, they don't care if it's scored or not. They're going to just gobble until they're either so inebriated they can't gobble anymore until they finish it. We're not going to stop that by this kind of my suggestion at this point would be to remove that category, cannabinoid edibles category, whatever number the data supports. We want to walk rather than run. I'm okay with that. 10 milligrams of the non-scorable.
Okay. Amy and then Malcolm.
So I just want to respond to this idea that the recreational market is non-therapeutic and only the medical market is therapeutic. So I don't think that we should be drawing a distinction in some ways, and I think this is an additional level of a conversation that makes it more complicated. I think that just because I am an adult use consumer versus somebody who has gone and obtained a medical card, that we should view everything, or these decisions for recreational, as how high is too high or what is an acceptable dose, because I think there are a lot of people who are coming into the adult use market who are going to enjoy the therapeutic benefits of cannabis, and that we shouldn't say you have to be relegated to the medical market if you want to enjoy those therapeutic levels. And I think that that's another level to this conversation, which is that the adult use market and the medical market touch each other in a number of different ways, and that the conversation around safety should be around not regulating how high is too high or what is safe for children. The truth is, children should not be consuming this, and so we should limit their ability to get access. And how do we limit the access? To me, that is what this conversation should be focusing on, not determining some arbitrary level of intoxication for two different markets. It feels like we're not answering the right question.
Malcolm, and I appreciate the audience with the way you did that. That was very respectful. Thank you. Malcolm, they get thumbs up and they wait for hands. And I thank you. Malcolm.
So I think part of what Amy's saying is that in the end, a lot of these, the way to address these issues comes down to packaging more than anything else, and we're trying to bypass that cycle. But I just want to underscore what Les just said about the non-storable edibles. I think the reason why this distinction got made, the 5 and 50 and then 5 and 10, is because somewhere someone confused our goals for adults with our goals for protecting children. So the scorable edibles thing is a marined out issue. It's how to help an adult person not eat too much of something. As Les said, it doesn't help a child. Kids aren't, they're not, you know, the little cracks that separate the parts of a chocolate bar are not compelling to a small child. So that's something to protect adults. And for adults, we've agreed on 5 and 50. And then going to 5 and 10 for liquids or ice creams or whatever that is it's someone saying, well, okay, an adult can't divide something into 4. I can see how it's hard to divide something into 10, even for an adult, but you can divide something in 4 or 5 pretty easily in your head. But when that decision got made, in the back of someone's head, they were confusing what we're doing to help adults with what we're doing to help kids. It's not logical.
Well, I think, though, that there is some evidence out there with regard to serving sizes in beverage containers, where people think of a beverage container as a single serving, even though there might be multiple servings. And so you're drinking a lot of sugar. You know, we have multiple servings of, you know, sugar in a beverage. So that may be part of what's going into the beverage calculation, is that when something's in a liquid in a beverage, people think of it as a single serving.
Sure, but it's for adults, and so on the label you explain to them and you make 4 lines and you...
And one thing about packaging is the reason we're not discussing packaging is because OLCC was given the authority to do packaging. So when you look at the rule authority, OHA was given labeling, serving size, testing. OLCC was given packaging. So, and OLCC does have rules that I think you guys know that require child-proof. So that is something that we're not going to discuss because it's not something that we can impact. I mean, you guys can talk about it, but I mean, it's not something that we can pass any sort of rule related to.
May I ask a question about the efficacy of those? So, of the efficacy of child-proof containers, because if it is, I think what Mowgli said is exactly right, is that if this is about protecting children, and we know that OLCC is making rules around child safety and packaging, and those rules around child safety and packaging have data-driven success, that's actually pretty important information for me. So if they're making, to me, these two concepts go hand in hand, I feel like we just hit sort of the sweet spot in this conversation. If child safety packaging works and labeling works, then this conversation we're having right now changes. To me, anyway.
So what's the question about packaging?
Well, the question is, does child-proof packaging work to prevent children from gaining access to things that are potentially dangerous?
So I don't know if Paul or Greg want to weigh in, but there's a federal standard with child safety packaging that, I don't know what the age is, but it's like a 4, 5, 6-year-old can't get on the package.
Yeah, there is a standard. It's not perfect.
Right.
But and just as I agree with your points very much so, and all of the exposures that we've reviewed so far have been in unregulated or non-child control incidences with these exposures. And I'm not quite sure where we are in the conversation, if we're kind of going down through some points. I'll overall say I feel that the 550 from a precautionary angle is agreeable to myself personally. I do believe that the non-scorable cannabinoid edibles do need to be very much reconsidered and be put into a similar category, as kind of an edible. Topicals, haven't quite thought through too much. I do believe that the cannabinoid concentrate and extract should be significantly higher, potentially up to 1,000 milligrams per container, because of the points that we've made so far, that one, this is a product that will likely have to be heated. Potentially there's some control that can be put into place where it must be a THCA-rich extract, where a child would have to love it to actually have psychoactive effects and actually consume it. And also from a practical standpoint, looking at a 250 or even 500 milligram limit on these concentrates is, from a manufacturing and getting those into small, is wasteful, and there's going to be some lack of precision there. Kind of along those lines, just back to the 5 milligrams, I think that may be tough too, from a manufacturing standpoint, to really get that into a scorable piece. So if you could kind of combine the scorable and non-scorable and put that into a controlled package that is going to be child resistant, that may be more beneficial overall for the intention of these limits.
Can I quickly just say too, you touched on a good point, and I'm going to bring up the ecological standpoint, and that's that you evaluate the environmental waste and so forth versus the public health benefits from these smaller sizes. Like Jeremy said, it's mostly THC and a CO2 penetrator from the safety standpoint versus the waste landfill issue. We need to consider that. Scott?
I want to push back a little bit on the notion that the edible, the caps, are designed exclusively for protection of children. I think from a public safety perspective, we all know what happened to Marine Dowd. I'm sure it was terrifying for her, but it's also kind of funny. But there were other instances that were not funny, and we did see a young man in Colorado contesting an entire cookie. I believe it was 8 servings. He was supposed to break into 8 and smelled his death, or jumped to his death, hurt his death. So there is a public safety reason to protect adults.
Please.
And we still don't know what the impact is on motoring public health, on traffic safety. So we've seen some data that we need to explore more. And again, I think the precautionary approach is appropriate.
And that actually reminds me that was actually part of the discussion with the Scientific Advisory Committee at their first meeting. It wasn't just around children. There was also, I don't think the Morbidity Mortality Weekly Report had come out yet from CDC. We knew the Colorado experience had occurred, and Colorado shared that data. And then there was a discussion about motor vehicle safety and how one beer doesn't put you over the illegal limit to drive, one glass of wine. And so why would one serving of marijuana put you at a limit that would be intoxicated or impaired? Why not allow users to sort of step up to the appropriate level? That was the discussion that the Science Advisory Committee had. I mean, this is sort of just, I'm trying to recount. That's correct, right, Katrina? Okay, yeah. So that was what they discussed, and they had also more complicated discussions. They talked about how 550 doesn't allow us to be essentially on the same level for data collection purposes as Washington and Colorado. I mean, half the people on the committee are epidemiologists, and they were worried about sort of there being a different sort of, are we a control then, or can we be in sort of the same studies? And so there were also some larger sort of scientific discussions like that as well.
That being over the limit with just one dose,
Right.
well, it's not even determined what the impairment level is for driving. It's just made up 5 nanograms. And in fact, I was just looking at this article, and this person, like 15 hours of abstinence was still like almost 3 times that 5 nanogram.
Yeah, I'm just telling you the discussion that the Science Advisory Committee
But you
had,
can't say, 1 glass of wine puts you over the impairment level, and cannabis,
Right.
one dose of cannabis
Right.
does, because it's a fake level that they've got.
Sure.
Also, it depends on the person. For every single
Absolutely.
one of these conditions, when my mom drinks a glass of wine, she's the last person I want to try. One glass of wine, right. She's like drunk, you know? We're gonna talk to her.
Jeremy, go ahead.
I think, I think there is, Scott brings up some very good points. We don't want to, and Shannon as well with the beverage, or these products that you could potentially eat a whole product and be highly, intoxicated for a new user. So maybe it's just a little bit, makes the table a little bit more complicated, but there is, instead of well, it is non-scorable actually, maybe a beverage is that, but what other non-scorable item? Ice cream, honey,
yeah, oils,
oils.
anything that's sort of,
Cake.
yeah.
Right. So what of those would somebody eat the entire product at one time and potentially overconsume? I think a beverage would be one. Potentially ice cream.
Not potentially ice cream. I think, definitely ice cream. And then there's also these sort of other sort of these odds, these different categories that we were, with the Colorado experience that they shared with us around salsas or I don't know, like.
Spaghetti sauce.
Yeah, I mean there were a bunch of cooking oils. There was a complicated one that we had to discuss. Yeah, then Washington also excludes a bunch of types of products, and then Paul, you alluded to this earlier, and this is the extra sort of handout that we put on the table and that we distribute to members today. If there's more than one, this is for Washington. If there's more than one serving in the package, each serving must be packaged individually in childproof packaging. So in Washington, for edibles, so if you have, they can have up to 100 milligrams in the package, right? But each one has to be individually so in the outer package, but in the inner package, each one has to be individually childproofed. So that's something that other states doing. I mean, is that?
I personally feel that a large child control package with freely non-child control within those would be acceptable in my opinion.
Might as well on that.
I think that what we should just say out loud, even though it's scary to say it, is that what we've decided, if we're going to go with the 550, is that balancing all of these different concerns and being really conservative about public safety, we've decided that we can have 50 milligrams in a single container. Like, that's the dose that we're willing to face the risk of someone who's cannabis naive or even a child accidentally get 50 milligrams. We're willing to face that risk in one container. So, I mean, if we really squarely admit
Yes, I mean that's what we've been struggling with. Yes, that's the.
Why do we have to keep struggling with this? Why don't we just mitigate it and have some logic with the thing? 50 milligrams, one container, up to 50 milligrams, one container across the board. Just seems logical. You want to use logic, right?
Are you saying
I'm saying we
eliminate the
combine
non-scorable category?
Exactly. It's a category that's. So every person wants, in this category, from what I know in my experience, everyone wants to give someone the appropriate dose. So we collab with Cream of the Crop ice cream. We found the appropriate dose in a 4-ounce ice cream container. Single serving size is 25 milligrams. That's how much everyone that we've given the packaging to on every single level can handle the dose.
How big is
want
that?
more? It's 4 ounces. The cup is big.
The little cup?
Dixie cup. And if they want more, they can eat another. But with 2 of those, I'm kind of feeling it, So by the time you eat the other. So the reality is even if it were to be 100 milligrams, I'm kind of, the devil's advocate in some ways. I would not want my kid to eat that, but I wouldn't worry about it if he did too much, honestly. So that's my reality, and I got a 3.5-year-old that's extremely aware and knows not to get into medicine because I've informed him of all the levels of what medicine are, and he's extremely aware of all those conditions. And he knows the symbols, he knows the signs, he can see if there's a leaf on it that's got medicine in it and stay away from that, you know? Because I've taught him and informed him of all that, you know? So this is why for me, I'm like, oh, this category that's completely, you know, has so much ambiguity and no real logic, and it just doesn't seem like it fits anywhere. But that's just me from a position of freedom aspect, you know? So.
Can we take a break? I need to go to the bathroom, but I don't want to miss
we were going to
any
take a
of
break in 10 minutes anyway, so yeah, let's just do it now.
Why are we here? Yeah. Want to go? Hey.
They haven't touched on topic yet.
You want to go grab a bite to eat? Sounds like, wait a second. I don't have to.
Till 12:15. Okay, so here's what we're going to do. We are going to adjust the schedule for today a little bit. So we have currently somewhere in the neighborhood of 45 people signed up for public comment and 15 minutes of public comment. So do that math and you see everybody gets like 15 seconds. So we're not going to do that. So what we're going to do is we are not going to talk about medical serving size today. We are going to only talk about retail serving size today so that we can continue to have a complete discussion about this. We will start public comment at 11:15 to give people 45 minutes of public comment. And if you don't have, and we'd like to keep the comment restricted to retail, and then we will come back and we will dedicate all of the next meeting on the 25th to medical. Does that sound acceptable? This is a proposal. How does this sound to RAC members? Amy, go ahead.
Timing and everything, it's almost close to the 10 March, sorry. Have a snack, right? Let me eat the one I promise. So, are we going to...
Can you speak up,
Yes,
please?
yes. So Amy's question was based on the...
So my question was, sorry, I was eating. My question was whether or not with the timeline, we were going to have enough time if you needed to make adjustments and come back and talk about them. I mean, I think that's right to give everyone a chance, but I know the timeline's really tight.
So the concentration limit rules are effective now, right? Because they're temp rules. They go into effect in April. So we're talking about changes that would be made for the permanent rules that would go into effect by like the end of June, which is when the temp rules expire. So there's going to be, I mean, unless OHA decided to do another round of temporary rulemaking, if there are changes, those changes aren't going to be effective until the summer.
Okay.
And OLC, and with retail in particular, OLCC stores shouldn't be open, right? So hopefully right.
Michael, what will we do about the testing?
Yeah, so that's the other discussion. Do you guys want to have another meeting in January?
Yes.
Yes?
I mean, I want to make sure we get this taken care of with everyone's point of view accounted for, and we really take in all the information and might make the right decision.
So we could do a couple of things. We could find another day in January to meet after the 25th. Or we could extend the 25th meeting like we did that meeting in November and do an entire day, which was a lot of work.
Well, that sounds great for me.
It's good for people who are coming from out of the area too.
These meetings, we just get going, it seems like by noon, you know?
So, does that work for folks? Positions, you guys think? Okay. Okay, so potentially then, it looks like what we're going to do is we're going to see about extending the 25th to all day. So I'll find out if we can get a room, a large enough room, and what our calendars look like on the 25th.
Can you just poll committee members about the order of the agenda?
Yeah.
I'm chairing a meeting that afternoon.
Okay, yeah.
I will not.
Yeah, so what is your preference on order of the agenda?
Well, I'm not sure. I think you should draft it and poll the members.
Oh, I see what you're saying. I understand what you're asking. Okay, yeah, we can send out a SurveyMonkey poll and see what folks think about. We've got basically 3 topics to discuss after today. We've got to figure out medical serving size, labeling, and then testing standards. And so we could just dedicate all of the 25th. Are you available? I should have asked that first. Okay, good. All right. I hope I am too. So we will we'll figure it out. Okay, so that's what we're going to do today. So we will talk about retail serving size until 11:15-ish, and then we will break and do public comment for 45 minutes because the three of us have to be somewhere else. We have to leave at noon, so for a meeting with the campus. So that'll give 45 minutes for public comment, and we want public comment today to be focused on retail serving size and what we discussed. So if I call your name when we get to it, and I'll remind folks of this, and you just want to talk about medical, hold on to it, please, and we'll talk about it next week. So, anybody have any comments for Paul? You were about to say something before we broke?
Sure, yeah, I think, try to get this out right. I think we keep talking about the 550 and the 10100 together. My concern with preschool age child safety is less about the 5 and the 10, but about what happens once it's open and how much could get consumed without thinking about serving size. Children that age are small, so it's a smaller dose has a larger effect. An average gross child weighs about 20 pounds. So about a fifth the size or less of an adult. They're obviously curious, and labeling is not going to be a solution for children of that age. So it really has to do with how much is available once you open it. When you have this precedent from Washington, it's a single sentence. I think it's that kind of thing would work for me. Again, it's not about the 5 or 10. It's about what happens once it's open, and that line simply reads, if there's more than one serving in the package, each serving must be packaged in a child-proof package. So that, I think, satisfies the child safety thing. The other thing I think, and I always try to come back to, is that we are operating under the Cole memo, and I think a cautious approach will help keep us out of excessive scrutiny. I think if we don't take a cautious approach, we might invite scrutiny that would then be damaging to the whole.
So, I mean, for me also, this, the whole idea here that the child is going to consume, the child's not supposed to get to the medicine or the product because it's in a child-proof container. So do these child-proof containers work? Because if they work, then we don't have to even think about this because everything's in a child-proof container. That's just my perspective, so I'm confused. I'm just a little confused. Is a child-proof container that works federally across the board not working for us?
Well, the problem is when you have more than one serving in a package, and so the packaging rules require that if there's more than one serving, it has to be capable of being made child resistant again. But you're assuming then that people are sort of resealing them or not taking it out of the child-proof packaging. So there's always the chance that the products are not going to be in the packaging.
Yeah, that chance is, we all understand the reality of a lot of stuff. So that's why we're kind of everyone's like, whoa, 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 like what are we doing here? Like, are we going to start like packing everything? And, like we're very excessively packaged anyway as America, so are we going to keep doing that thing? Like extra plastic, 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 more plastic, more plastic, more plastic in every bit of your plastic so you can get a little bit of your whatever high you want in your plastic,
And so to answer your question though about the sort of the child safety component. So the federal standard is only required to keep a kid from getting into a product until a certain age. And I don't remember the age off the top of my head. It's 5 to 5. Okay.
It's a good standard.
It is a good standard.
They take like 50 kids under age 5, and I think 80% of them can't get into it, and they take a bunch of seniors, and most of them have to be able to get into it. So it's actually a functional test. I think it's not perfect, but it's quite fine.
But the other side of it is, though, I mean, it's typically something that's so. If you leave your aspirin or capsule out on the counter, or there's a chance the kid bites into it, chews it, it tastes terrible, they spit it out, right? It's what Paul brought up earlier. Now, of course, child poisonings happen. That's why we have a poison control center. Unfortunately, Rob's not here today. But we're, again, talking about a product infused with marijuana or that contains marijuana that looks like a cookie or a cake or a candy. And so that's where it is a cookie or a cake or a candy. And so that's where our public safety lens and public health lens comes into play. And so that's why we're taking this sort of approach. That this is, as we mentioned several times, sort of 5 and 50 is twofold. One is for the instances where a child is able to defeat the child safety packaging, or in instances where a child is old enough that it doesn't actually apply to them, or it is actually just left on the counter. And then the other side of it is to protect novice users. So, or
So basically, it's the same, because if it gets, the kid gets into it, if he can get into one childproof container, yep, he can get into all the other 5 or all the other in there, it's gonna be even easier, because those ones are gonna be even easier to get into than the big bag, So we're just talking about a dosage level on keeping someone safe, right? We're talking about safety, public safety.
And I'm going to say I'm not an expert on this, right, at all. But the other way that it's been described to us is that it's not just being able to defeat the container. It's the amount of time it takes a 5 or 6-year-old to defeat the container. So now what we're talking about is, with the Washington proposal, you have 10 of these products. How long is your 6-year-old out of your sight that it takes them? If it takes them 6 minutes to defeat each container, how long? Well, you see what I'm saying?
This stuff sounds like parent, like awareness, what I'm seeing is if my kid has enough time to get into all that packaging, I'm an idiot.
Well, unfortunately, we have a poison control center, and
I know that, I'm just saying, I haven't heard of one case in Oregon where a kid had a really bad problem that went social, it was public, right?
I would reiterate too that can we balance some education campaign against, a massive amount of plastic of wrapping every little dose. I think the education part is so key, and yet, that's not in any of these rules.
We are in
It's
Oregon
really
too.
sad.
This has been a really big facet of our community and our reality of being like, hey, let's not do things that are bad for the environment. And this packaging thing, when I start talking of doses and I start thinking of all the plastic, and I look in the ocean when I go to a different spot, and I see all that packaging and all this stuff from all the medical community and medical system and all the whole thing, it's a huge issue in my mind. And that's why I'm kind of so adamant about making a point about it,
So youth prevention is something that also is under our responsibility, that it's just not talked about here because it's not a part of these rules. So there's a
But I'm thinking parent education.
That's a component. That is a component. That is a component of this.
Okay, so I'm going to divert a little bit from packaging, and I've just been looking a little bit at some of the exposure data that was presented, and actually talking about appropriate amount in a package. If it's packaged correctly, it should be, obviously. So what was presented in the JAMA table here, I think that was presented to everybody. We have, one of the questions that was asked earlier is, what is the dose that brings a child into the emergency room? Per this table, the mean dose ingested, and I'm not sure where they even figured this data out with dose ingested, because these are unregulated, untested, unknown products that they ingested. But if we are going to go with this data, 3 milligrams per kilogram observation in the ED. For a 5-year-old, I just looked up quickly on the Google site. Average kilograms for a 5-year-old is 19 kilograms. If 3 milligrams per kilogram is the dose, that puts us at, well, I did the 10-year-old, would be about 93 milligrams. So 3 times 19, that's 60 milligrams there for 60 milligrams for a 5-year-old to even be observed in the ER. Not even admitted, if I'm understanding this table correctly. Obviously, I'm not looking at all the data or putting very much review into this in detail right now, but just trying to do some rough numbers. If we're looking at 60 milligrams for a 5-year-old, 90 milligrams for a 10-year-old to even be observed in the ED, there's 3 instances of this. I think overall looking at the 50 milligrams as the amount in the package, potentially not demarcated, is acceptable based on at least these rough calculations, and potentially even 100. If we are going to look at dosing that puts children into an emergency room. And I do urge the precautionary approach, but I think we do have to continue looking at what exposures we've seen, what those doses were, and also consider that all the exposures were in unregulated, non-child resistant packaging.
I'd like to respond to 2 things. One is the idea that if we don't do this, our program will come under scrutiny, and 2, the idea that if Colorado could do it again, they would do it differently, and in that order. The first is that I think we use that idea that like, if we don't do this, this whole program might be in danger really often in this conversation when we're going to cross some sort of threshold of regulation. And we've heard it in the Rules Advisory Committee, and we've heard it at other meetings like this. And my feeling is if Colorado hasn't come under scrutiny and Washington hasn't come under scrutiny, that it seems unlikely that Oregon would be targeted for additional scrutiny if we match their regulatory structure. The second one is the idea that if Colorado could do it again, they would do it differently. Well, Colorado did do it again. So, I mean, they restructured their edible regulation to come to this place of 10 and 100. So they did have a chance to do it again, and they chose to do it the way that we're looking at now. So I think that to say that Colorado's public health made these recommendations, and I didn't participate in that process, so I don't know why they didn't choose a lower dosage, but they didn't, and they did have a second go at it. So I think those two premises to base this conversation on are kind of challenging premises.
Right. Thank you, Amy. So folks know what Colorado did, though, is Colorado is requiring a universal symbol to be contained on every dose, or every serving size. And if the symbol can't be, I don't know what the word is, embossed on the dose, then it has to be a single serving size.
And so and we're talking about dosage right now. And so when we move on to a conversation about serving size or symbols or packaging and labeling, that's a separate conversation. But in terms of adjusting the dose, Colorado did have an opportunity and chose not to engage in that. Or they did engage in that process and landed where we're trying to get to now, I think, in the industry.
So any other, yeah, Dave?
Yes, I did some research on child-resistant packaging. In 1970, Congress passed the Poison Prevention Packaging Act, requiring child-resistant packaging for many household drugs and cleaners. Combined with increased education and awareness, it led to a decrease in overall exposures. In 1990, there were 22,141 cases, and then in 2006, there were 11,964 cases, which in 16 years was a 46% drop in cases of overall household cleaners nationwide, simply based on having it in a child-resistant package. So there is data that shows that these packages work.
All right, so any other thoughts on sort of the first two categories in the box? So the scorable cannabinoid edibles and the non-scorable cannabinoid edibles. So I think what we've heard so far is that there's a, there's a sort of a back and forth that we've had today around sort of the serving size being 5 to 50, maybe being a request to be increased to 10-100. There's been a discussion about should it actually maybe even be more like what Washington's got, which is either 550 or 10-100 in a requiring every package to be single serving size. There have been recommendations to do away with or make equal then you would just do away with the non-scorable cannabinoid edible category, or to consider. Well, I guess we haven't talked about that. What if this category still existed? Would it make any sense for it to be different than the edible category? So if we had an edible category of 550, right now we're proposing scorable, non-scorable, so ice creams, sodas, etc., to be double serving size, 10 milligrams. Would it make sense for it to be 4, or if we're going to increase it, does it matter? Sort of
The only reason to keep it as a category would be if we wanted to make it 540 instead of 550, because of an argument that you can divide things in quarters. But obviously it's a lot of hassle to keep a separate category just to make it 40 instead of 50. And I think once we agree that everything we're doing in this category is for adults and not for children, it becomes less significant. You require a spoon with a serving size or demarcations on the side of a bottle.
So you confused me on that last part about why aren't we talking about children with this category?
The non-scorable edibles being kept at 10 is not something we're doing for kids. We're doing that for adults. We've already decided that for kids, we're willing to have a 50 milligram
I understand your rationale.
cookie or
Okay,
whatever.
thank you.
So I think we should just do away with it.
I don't want to say we've agreed on the 50. You know, the example of a 5-year-old is about 2 or 3 times the size of a 2-year-old, and the majority of the poisonings are under age 24 months. So I think you need to take your thing down from 95 or 50 down to 50 or 25. And Dr. Hendrickson's calculations are that for that toddler age group, that 20 to 30 maximum per package size would be could lead to toxicity. So a margin of safety would be lower.
And I think it's interesting, at least from the materials that were presented from, I'm sorry, I forget his name right now, poison control doctor. What I saw was that the conclusions of most of those studies suggest that the poisonings under 2-year-olds are typically rare, and it actually states this, and I can pull up the point, but they're typically in older toddlers who are around and kind of can find them and pull them up, and that's something I noted here directly from my review. So that's interesting to see where, the concern of 24 months or lower finding the product, or are we addressing, a toddler to a 10 or, adolescent age. I thought we were addressing from a 2-year-old to a 10-year-old kind of range, personally.
So pediatricians will give you some definitions now.
Yeah, please.
Infancy is up to 12 months. Toddlerhood typically till about age 2, and then preschool, age 2 to 5.
Okay. This is also
But
all
again, the whole point of the child safety thing, to reiterate one more time, is that they're little, right? So that 50 milligrams, maybe not too bad for an adult, but it's 5 or 10 times higher for a small child, right? So again, the whole point of child safety is don't read, they're really little, and they're really curious.
in an FDA-approved child-proof container. So we're in an FDA-approved child-proof container. FDA, federal, guidelines. And it's in that child container, and what statistics show that, there's been a massive, almost 50% decrease in once education, childbirth, and all this stuff happens. So it's like, from my standpoint, but how rare a child is ever even going to get its chance to consume a recreational product with all these parameters set in place is seems extremely low. Unless we disagree with the federal government's already approved through their standards of safety.
No, I think what it comes down to is that child safety isn't one component, it's a comprehensive approach. And so it's the child safety packaging. In this case, we're also including serving size into this. There's parent education and responsibility, and then marketing and appeal. I mean, those are the...
Which to me, in all contexts, sounds like it mitigates a child getting his hand on the material.
Well, that's why I'm saying it's multi-component.
Yeah.
So that's why, and so
Conditions,
this is a component of it, is the approach that we're taking. Okay, any other comments on this part of the discussion? So,
Michael,
go
I'd just
ahead.
like to reiterate what Dave was talking about there. It seems to get glossed over, is the education component that goes with the child-proof packaging.
Right.
Let's not underestimate that.
May I ask, so if we're gonna move on from this, what would you, and I asked this previously, so when we come back and regroup on this conversation, what are your expectations of those of us who are advocating for a different?
So, we've got notes here that, you've asked for some very specific data. And so I think we're going to try to put our heads together and figure out what data exists and what doesn't exist. And then I think we sort of talked at the break a little bit about potentially coming up with some scenarios, bringing them back next week and having a discussion, or in 2 weeks, and having a discussion around that. So I think what we'll do at the next meeting is we'll distribute our edits beforehand, and we'd like to go through and talk about our edits.
Is there there are a lot of people here today who have feelings about this issue. We've seen, mass emails, and we've seen letters, and we've seen a number of ways to communicate what their hopes are for the end result for this. What do you think for people in the audience would be the most effective way to communicate what they would like to see happen?
Yeah, I mean, it's not helpful just to say, I want this because I believe. I think it's helpful to say, this is like, here's some data, even if it's, it doesn't have to be peer-reviewed published data. But I mean, I think, as I mentioned, I think it was really compelling when we heard from folks that we had missed the way that we define cannabinoid tincture. It was inappropriate, and they gave us a definition that was a more appropriate definition, and we have, I think we have the intention of changing that in a way that's more appropriate, because that's what is on the market, and that is a more accurate representation of the category. The fact that we had also miscategorized, so I think that's not data, that's not peer-reviewed studies, but it's sort of like, hey OHA, you didn't realize that there was an unintended consequence of the way that you define tincture, or the fact that you had no way for us to capture capsules, which is, by the way, a discussion we need to have before the public comment. I don't know if I'm answering your question.
I think that what you're saying is that when everybody here communicates that you would like to see, or what would be most productive would to see, what is your ask and why are you making that ask, even if it is anecdotal?
Yes. And by the way, Tom Frieden, who's the CDC director, recently said that the plural of anecdote is not evidence, right? And we realize that, and so I think we're working in a universe where there isn't a lot of evidence, but we'll make the best decision based on what we have. We've got about, okay, so let's so just tell you, so much like that definition of tincture and the fact that the levels for tinctures and extracts were probably more appropriate at 500 milligrams as a minimum, We also heard from representatives of the topical community, and I don't remember exactly what we had in our original, what we proposed for public comment, but representatives from that group indicated, those manufacturers indicated that 1% was a more appropriate, something more like 1% of topical. Is that not correct? And then we
No.
Please, Mallory, go ahead.
Well,
Because
first of all, no representative of the topical industry would have said that.
Oh, I'm sorry. Yeah, I'm sorry. I'm correct. I missed. The 2% was too low, and that it needed to be increased. I'm sorry. So we heard from them that was too low of a number. But again, we don't know what the appropriate number is. So we don't know where to set that. So we haven't received recommendations on this is what that level should be.
Well, a lot of these things as well is where we kind of come into these problems. So really, to have a high application topical that really works well, you want it to be pretty strong.
Right.
I mean, it's just it works really good when it's like 10-15%.
Right.
To me, nobody is asking.
And also just as a consideration, the various forms of topicals, be it an oil, liquid, or a transdermal patch or a cream of some type, depending on if it were, for instance, an oil liquid that could be used as an edible or as a topical. Is that addressed on the packaging and the claim of the manufacturer? I mean, because there's going to be, a limit that they would have to fall into either or if there was two routes of administration for a topical or edible product.
Oh, so if you have a topical, it can also be consumed?
That could be consumed, for instance, like a coconut oil or almond oil, cannabinoid infusion that was activated that could be put on the skin.
It has to be both standards is the way that we've got it written now, as opposed to how it's marketed.
Okay.
So,
And anything that's going to be ingested on the packaging side doesn't have to be ingested.
Okay. So if it were stated that this is for ingestion, it would have to meet the edible requirements, and if it is stated that it is for topical, it would
not to be
ingested.
So then we're going to get into this tincture reality, right?
yeah, that's what I'd like to work down. Yeah.
So in that context too, with this fluid ounce sizes, that would, that's a pretty,
Well, before we move on though, I mean, I think we need sort of feedback on, like, what are the appropriate levels for topicals? How do we identify that? This isn't a discussion we need to have today,
okay.
but I'd like to have, like, I don't know if any of the, and again, we're talking about for a retail market. So is this appropriate on the retail market, or should this only be on the medical market?
Well, I think
It's the first, hold on. Wait 1 second, guys. Okay. So the one question is, should it be on the medical market only, or should it be on the medical and the retail market? And then 2, do you have experiences, or not experiences, do you have examples of what's on the market currently, so that we can get an idea of what those products are and what the appropriate levels are? And then remember, we're talking about THC, not like active THC, not just the THCA. So,
THC is, once it's activated, it goes transdermal easier. So
okay. So go ahead and jump in.
I think it's very appropriate for the retail market. It's like buying not everybody wants to go get the medical part, but if they have light arthritis or something, and there's a topical, they're going to want this, and you're going to want it to be fairly potent. John, you know more about this, and then it's longer. I'm not sure you can get high from rubbing on a bone. You can't. I didn't think so.
Because it has to, even THCA, it's psychoactive for personally. If I were to eat a raw nug and just chomp it down and eat it, I would get high off of that.
Right. And you can bring those cannabinoids across the skin barrier.
You can.
Effectively with the right formulation, definitely.
You need to have something to do that.
Yes.
PSO or, whatever that would
You're
require
correct.
from that. But just in itself, no. I have actually written an article on this.
Okay, so that answers my question about is it okay?
Yeah.
Okay, so then yes, on the market, on the retail market, that's fine.
Absolutely.
Okay. And then examples of products that are on the market now?
I'll bring one after the break.
I can get you a bunch too.
And you don't need to bring the products, I just need.
I meant bring you the information.
That'd be helpful.
Michael?
Yeah.
I was actually looking in, I was at a dispensary yesterday. And I found, for lotions, I found they were in between 2 to 8 ounce containers. And I found nothing that was more than 500 milligrams.
Okay, that's what I needed.
Michael, what practical purpose does having a limit on topicals serve from a public health standpoint?
You have to.
The legislature, is that?
Yeah. And also something, that's made with organic shea butter is very edible, consumable, and very easy content.
But are people, it's not like
Kids,
gonna get into a
we're talking about
lotion.
kids still.
My kids don't have lotion.
Yeah, my kids don't eat my kids don't eat that stuff
They'll eat
either,
chapstick.
but the thing is that we have this context of what we're going for right now, and, I don't know, organic shea butter tastes a lot better than chapstick.
They eat laundry detergent now, so they're going to eat anything. Kids eat anything.
Is there a child safety concern about kids consuming topicals? I know this is a sort of a
My
esoteric
guess is
question.
they're probably ignorant about what the products are and whether, obviously lotion we conceive of, probably no, but it's something that does have, by the definitions, the ability to be consumed, not taken.
So, our inclination here is to set a standard that makes sense for the market, based on what I've heard today. And so I think we just need to get examples of what's on the market so that we can sort of allow for those types of products. Is that fair? Yeah, okay, that's the approach we're taking. So let's get some more, so if RAC members could communicate to me, and if members of the public might happen to have any products that you want to share with me, I'll be happy to talk to you later. Right, I know, so we'll talk about it later. I know.
Everybody's got the
So
numbers.
just basically send you all the details.
Send me the
of the
details,
products
yes,
that we got.
correct, yes.
Okay, perfect.
Right.
So we're down.
I'm not asking for people to bring me products.
No, we just want to bring you the numbers.
So, okay, so, great, so any other discussion on topicals? No, all right, tinctures. So we're gonna expand the definition. Our intention is to expand the definition, and we'll bring that at the next meeting. Currently, the definition only captures tinctures that are derived from alcohol-based, correct?
I think Washington has something.
Yeah, so our intention is to expand that definition, and we are considering increasing the amount.
Is there a proposed idea of what we're talking about?
I don't know yet.
Because I mean, and also, that's what I was kind of wanting to get at, was this one fluid ounce.
Right, and so it might be more, so let's say, for example, if, I don't know.
I'll just give you an example, that I make an alcohol extract, organic ethanol, and I extract whatever product I want to extract from either be ice, wax, to plant material, and I can get my concentrations up over 500, 600 milligrams a milliliter. It's still dosable by the drop, so when you're talking of, a dropper that's 25 to 30 drops and it's 600 milligrams, so you divide that by 30, we're starting to talk real therapeutic dosage value, So for me, I'm kind of concerned, and I can deliver in a 1 gram size, which is or a half gram, 2.5 milliliters, But it's still, even in that context, I can't deliver this really, this product that I think should be delivered. And I'm not, but I'm just saying there's that on its most concentrated format of tincture to, these tinctures that don't work.
And remember, we're talking about on the retail side. Okay, all right.
I'm still with
Well, you said therapeutic value, so that's where
I know, but I'm just, this is, I'm just giving a
I understand
context
that.
full reality.
Just as a kind of an off comment, would it be possible to make a container size be in metric units, since everything else in the table is metric?
No, ounces. But I'm curious what my question was, this 1 fluid ounce that's dictated in here in law, in the pool, is that going to have a problem? Does it have to be served in a fluid ounce? Does it have to, is that what's going to be?
A tincture?
Like, can we do anything we want? Because that's it's in there, it's right as a pool.
Yeah, it means up to, so,
Anything up to.
yeah, so we can make that clear.
Actually, just to clarify that real briefly,
Yeah.
so that would be the container size may only contain that amount of liquid.
Correct.
If there was a limit on the amount of THC or active ingredient, why would you limit the amount of total liquid?
Is this a botanical farmacopoeia? Is this like from the pharmacopoeia size of maybe if there's that much alcohol, then you have more than a fluid ounce of alcohol? You have
Because
You're unintentionally mandating higher concentration per gram.
Because you may want some folks may want very low concentration, have a big bottle with very low dose.
Exactly. I mean, for me, I'm going toward the opposite end of that, like intentionally. So, meaning I don't want someone to have to take a bunch of anything. I want them to be able to get a really high dose and really
So
small.
would you eliminate the container size? Is that what you're recommending?
Yes, I would
And
recommend.
just leave it as a THC?
As a total amount of active ingredient in whatever size bottle or for all, because this is the only container size that has an indication. And I don't think it's appropriate. In my opinion.
And if we are moving this up to say, even if we're moving it up to 1,000 or something more appropriate, like 1,000 milligrams of THC in a container, plus 3,000 milligrams of CBD, that starts to become a product that everyone, even rec and can use as recreational, therapeutic, whatever. It fits a lot of categories and it fits something that's safe. And if a kid drank the whole thing, man, maybe the CBD would contradict all that THC, and the kid wouldn't get high, who knows? But there's a reality to it that we can start talking science to at least, So.
I think we need more information on this, and I know we met with people who manufacture the tinctures, so maybe next meeting, we'll have the updated, right, the updated descriptor that is more inclusive of some of the other types of tinctures that are out there. Maybe what we can do is post that when it's posted and send it. I know I'm specifically seeing people that we talked to about this who make it. Can we post it and then send it and have the public and solicit public comment on this specific table and the issues with that? Would that be helpful to the RAC? Because I don't think we can decide this today necessarily if we're not looking at the updated.
It would be a nice thing, I think, for everyone and everyone involved here for sure, and then everyone involved would feel
Yeah.
good.
Okay, thank you.
In closing, my cell phone over the last few hours has kind of blown up a little bit. A lot of questions about when everything takes effect again, and we sort of had a break since December, and the meetings are getting larger. Can we kind of talk about what we're developing here and summarize so that everybody in the audience kind of knows a little bit more about, we're developing rules that will take effect temporarily, then final, and just have a quick announcement by you on that. Yes, at the end, yeah. I thought we were getting there, yeah.
Yeah, we're close.
Sorry.
Anybody else on tinctures? Concentrates and extracts.
Can I start there?
Yeah, please go ahead.
Okay. I think there is an industry standard now, of course, that we follow. Again, it's not decarboxylated. You look at a CO2 pen or typical containers of black shatter or whatever. It's normally sold in 1 gram. And concentrations of THC vary according to the product. It's anywhere from 50 up to nearly 100%, depending on the methods used. So it's a tough one to just say, you know, concentration. You're almost better in container size here.
Yeah, that's what I was wondering. So with what you just described, if it were 1 gram, then you would say container size, or it would be like product size as opposed to container size, right? So the product amount would be 1 gram, and then the concentration would be up to 90% THC, 95, 1,000 milligrams. I mean, just say.
I think
that was an example of math. Okay. But that's how you're proposing that it would look.
One company I'm involved with, I think we haven't tested it fully yet, but I think it's looking at 98%.
Yeah,
okay.
We're doing 97, 98 right now.
You have an alcohol extract.
And again, from the child safety standard, because that's what we've been talking about off and on today, if a child ingested unheated concentrate, it's not active THC?
Correct.
No. So what does inactive THC ingested by a child do?
I would submit that it would be variable based on what extract or concentrate they ate, because the marketplace is very diverse right now, with some products that are nearly all acidic form, some that are about 50-50, and some that are full decarb products that are out there. So without some controls over the acidic content, or it would be variable, and it's not controlled at this point, and none of these regulations would control that.
But for a kid to eat,
Yeah.
you know, like a gram of sap.
I know.
It's not attractive.
It's not attractive product. No, I understand that.
I think with the pens too and the cartridges, maybe some argument.
You have to break into the package.
Yeah, I mean, that's childproof right there.
And you would have to, potentially have to put that on a battery, and if it was itself.
Okay. So.
Yeah, and I just want to point out, like, I agree with these guys. It's a different use. It's a different format. It's not sort of the bingeable the way snack.
Okay. And so, a gram is the typical amount that's sold. Are products sold in half grams or no?
Yes.
Yeah, sometimes.
So the market
is generally on a normal vape pen, at least the ones that we're working with, it's a gram.
And then I think there's examples also of like the concentrated dab products being the more popular ones being a gram as well, correct? Okay. All right, that's helpful. Any sort of comments or thoughts about?
Well, we're getting to the next one.
No, we'll talk about that in the next. That'll be the last thing we talk about today, because we need to talk about does it belong on our side, on the recreational side. What we're talking about. Yeah. So we're going to start public comment in a few minutes. I'd like to talk about doing away with this last category, sort of no longer existing, cannabinoid product not edible or topical, and creating a category for high, I don't know what we call it, like high dose THC products or high serving THC products, something that would encapsulate capsules, suppositories, patches. And I think the agency recommendation or sort of inclination would be that doesn't belong on the retail side, only on the medical side, because we're talking about a medical sort of delivery device.
So versus if we're saying and it would hold that this 550 is an edible, if it were to be a pill that's going to be focused on getting someone high with that 5 milligram dosage, or this other, so that would be.
If you wanted to sell 5 milligram pills
to get
in a 50 milligram
that would be
package,
where we fit.
as an edible on the retail side. Yeah, I mean, I think what we're talking about is potentially creating a category for capsules that are much higher than.
Yeah, so that's what I'm saying, so
500
that
milligrams.
wouldn't even fit in what we're talking about anyway.
No.
It's not for this table anyhow.
No, and that's what I'm discussing. Yeah, so I'm not talking about what the medical serving size would be. I'm
I know,
asking,
but
yes,
I'm
correct.
I'm with you, so
Yeah.
what we're saying, we're Xing this product out,
Mhm.
and there's not gonna be high dosage pills in this program, and.
That's the
if-
proposal from the agency.
Okay, so then then if we do want a pill that's gonna be focused on a recreational use, it's gonna be a 5 milligram pill, and it's 550. And that's kind of what the system is proposing they would like to see.
So you're saying, okay, I
Is that
understand
what
what
you
you're saying.
said?
That's what I heard you say.
Okay, but that's what I
The
thought
problem is, we don't have this extra category here, and there's I'm not sure a capsule would fall into the category of food. So we would have to clarify that if we're not gonna have this.
Well, that's kind of what I'm saying.
Is there room for that on the market?
I mean, to me, for sure, I mean, a very titratable, non-edible, meaning something that you don't have to eat a chocolate, you don't have to eat ice cream, you don't have to eat some corn syrup candy, little robot, you don't have to do something, you know? So you can have a pill that's very chill, very easy, dosable. You know, that sounds like about the best thing for the record.
And it meeting whatever standard we set for scorable cannabinoid edible.
Whatever we find is right for that type of product.
As just real briefly on this point, you know, maybe it's the case if cannabinoid concentrates and extracts do get increased, you can purchase that, you know, concentrate or extract and put that in a capsule if you need to.
Make your own
Make your own. It's really easy and still have access to that higher amount, potentially, you know, the capsules, potentially solving that problem.
But if it's a THCA product, because we were talking THCA versus THC, is, you know, most concentrated. No, most people, if you're selling THC, not THCA, they're not gonna buy it. You know, and I would say a concentrated format.
Amy, and then I think we're gonna need to.
So I just was checking in with someone who was wearing a transdermal patch, and I guess I would again urge that we not draw quite such a clear line between this idea that recreational is just for getting high and medical is just for treating particular illnesses or pain. I think that there are many people who are going to be patients who are going to participate only in the adult use market, and I don't want to say that you know, God forbid somebody you know has cancer, that you're going to require them to go get a medical card now that cannabis is legal for all adults to consume. To me, that is not an appropriate place to land on this, and I think that what she was pointing out about her transdermal patch is that you cannot regulate that the same way because it releases 2
milligrams an hour for 24 hours.
So it actually, the dosage is a slow release, just like if you're wearing a nicotine patch. So I guess I would urge that we, even though we're definitely going to land at a higher number for the medical program, that we don't just treat these as the same product as one is meant to get high and another is meant to be therapeutic, because I think those things can meet each other somewhere else.
Can't we have the transdermal patch in its own little area? I mean, can't we have this segregated to where we're extremely clear and doing it in that format that's like based in all this awareness so we can segregate it appropriately? Is that just not possible?
We just need a proposal. So I think what we'll do, we've made a proposal, it sounds like that's not gonna work. So I think what we need to do is come back and we'll bring and what we've worked out on the category, and then I think what we need is.
And we send you guys also the information that we think.
And they say, you know, you should include transdermal patches and X, Y, and Z in the recreational category, and this level is appropriate and how I would do it.
So, because through the science of the transdermal patch, it is released in a dosage format, so you're only actually through science proven that you're getting that, you know, so it.
So, Paul.
Yes, so I support what John says, like, it's basically definitions.
Yeah.
This category is exactly this.
Yes.
Because I think some of these are vague, so that it just sort of leaves the things open to interpretation.
And no one-
I think
no
we're
one's
having this
eating a
debate
bad-
so that it's clear. So I would
Yes.
support, the table might be a lot more rows, but you'd know what it was in each row.
Okay. Yeah, we can try that. All right, yeah, I know what time it is. Thank you for the polite pointing. We're gonna, and I meant that sincerely. So if RAC members, so today's the 11th, our next meeting's 2 weeks from today. the 18th is a holiday.
Yes.
So if we could get comments back from RAC members or documents, sort of examples of things by Friday, this Friday, is that, or heck, the end of the day, Monday, the end of the day on the 18th, that will do it. And that'll allow us to sort of, right? Yeah. Okay, so the end of the day on the 18th, or at least before I come into work on the 12th, like get us materials, and we'll incorporate that into all the sort of decision making we're making for the next draft, and we'll make an effort to get you materials as soon as possible. Okay, so we're going to take public comment now. We are only taking public comment on what we've discussed today, so please keep public comment to retail marijuana products and classifications related to serving size. Based on that, who signed up? I'm trying to figure out how much time we've got. Who signed up for medical who doesn't want to comment now? Please raise your hand. So
I'll be here in 2 weeks, Carrie
that's fine.
Stanberry.
3 or 4 people? Okay. So we're going to need to keep public comment to about a minute and a half to get everybody in. And we will take public comment through writing at our email address, rules.publichealth.rules@state.or.us. publichealth.rules@state.or.us. And if someone says something that you don't feel like, let's try to, also I'm trying to figure out a way that this makes sense. Let's try to keep our public comments to be unique and novel. So it helps for you just to come up and say, I agree with what the gentleman said earlier about X, Y, and Z. That is acceptable.
Can you repeat that one more time, please?
Publichealth.rules, publichealth, one word, .rules, at state.or.us. All right, let's get started.
Can you do what I requested, just to go over those rules?
Oh, yeah, okay.
Please, real quick.
Yeah.
So the concentration limit and serving size rules were filed as temporary rules in November. They went into effect on January 1st. They will be enforced starting in April. So in April, we're going to have dispensaries and not have retailers yet, or OLCC licensed processors or OHA licensed registered processors. After April, things transferred to a dispensary and transferred by a dispensary will have to meet the concentration and serving size limits that you see in the tables that we're talking about today. So that will be true unless OHA decides to do additional temporary rulemaking, changing things between now and April. So we're talking about making these rules permanent, making changes to the permanent set of rules that would go into effect by the end of June. Is that clear enough? Okay.
All right, I'm going to call people up in sets of twos. I also want to thank the audience. You guys were very respectful, and you adjusted to the request not to have applause, and I want to say thank you for that. Thank you. They have a round of applause. All right, so Kristen Anderson and Nick Rivas. And if you don't stand up, I'm not going to... Yeah, can we turn the mics on, and we'll just sort of be over here. Matt, can you? Rose is on her way. All right, it looks like Kristen and Matt. Okay, great. Nick Rivas, were you here? Nick, great. Okay, Kristen's not here. Helen Yang, the next person on the list. Helen is here. Great.
Well, it was on. That one's not on.
Yeah.
Turn on the shots. Try it again.
Is that it right there?
That one's not been working all day. Just talk really loud.
Talk loudly.
Yeah, public comment needs to be right here.
All right.
Good morning, Rules Advisory Committee members. My name is Helen Ying, and I'm the chair of Big Village, a coalition of diverse partners working to reduce youth substance abuse in Multnomah County. I'm also a retired vice principal and educator for 30 years, and currently a hearing officer for Reynolds and Parkville school districts. Marijuana is a huge issue for our schools. I increasingly see youth who are dealing with the negative consequences of marijuana use, and school staff are struggling to provide effective prevention and intervention. Edibles are particularly concerning because of their potential appeal to youth, the ability to go undetected at school, and the delayed onset that may cause inexperienced users, kids, to take large doses before the effect of THC is felt, resulting in dangerously high dosage consumption. I strongly urge you to set a 5 milligram serving size and 10 milligram package size in individual serving child-proof packaging for the following reasons. 1, for child safety, preliminary data from Colorado's Poison Control Center and hospital emergency room data show that numerous children have accidentally ingested their parents' or grandparents' marijuana edibles. This has resulted in significant symptoms, including children placed on mechanical ventilators and admitted to ICUs. 2, for good prevention practice.
Thank you, Helen.
Although parents are
Thank
not
you.
supposed
Sorry,
to get their hands on these products.
So we have to
some
move on,
probably
I'm
will.
sorry. So thank you for, we're out of time.
So
So I'm gonna
5
have to stop
milligram
people.
serving size,
Nick
10
Rivas,
milligram
you're
packaging.
next. Thank you. And we'll accept your comment written if you would like.
Sure.
Okay, thanks.
Can I
Nick?
finish this one?
Nick? And then next up will be Daniel Atkins. Daniel Atkins? Yeah. Okay.
Good morning.
Start calling you up.
My name is Nick Rivas, and I work at a early childhood education nonprofit focusing on children ages 0 to 5. And our work is founded on the idea that children are innately curious, capable, and creative. And these are characteristics that should be fostered in children to develop the leaders of tomorrow. Studies show that the first 1,000 days of a child's life are vital to their educational and health outcomes across the rest of their life. Their physical and neurological development of a child's brain are never more receptive to their environments than they are at this time. This is a time for young children to build an understanding about the world they're growing in. They explore the world with their full capacities, and at this age, it means with their hands and their mouth. Young children have been shown to access places and items that adults did not intend for them to get into. Studies of marijuana exposure in children have shown that the median age for unintentional exposure is between 1.5 and 2 years old. As marijuana legislation evolves, we must consider the impacts it has on the entire population. Just as tobacco and alcohol have regulations restricting access and exposure to children, similar supports can be adapted to ensure the safety of our most vulnerable community members. An effective approach to keep children safe will include effective packaging that is not attractive to children, limiting the effective dosage to 5 milligrams of THC, 2 servings per package, and child-resistant packaging for every serving. I would like to ask you to make decisions that have been informed about the lessons learned in Washington and Colorado in regards to safety for our youngest community members in the marketing and distribution of recreational marijuana edibles.
All right, thank you. Daniel, go ahead, and then Donald Morse next.
Don's not here.
Donald's not here, okay. Travis Miller?
Hi everybody, my name is Daniel Atkins. I'd like to start off by don't be an asshole and keep your medication in a high-up place so a 2-year-old can't get there. That's number one. Number two, when we're talking about the rules of the OLCC and packaging and labeling, it does go hand in hand like Amy said. Here's what it actually says. All products must be packaged in child-resistant packaging and labeling in accordance with OHA labeling rules. OLCC will have a packaging and labeling pre-approval process, including listing what can be approved or not. No packaging or labeling can be geared towards minors. This includes cartoon characters or look-alike products. Advertising cannot be attractive to minors, cannot promote excessive use, cannot promote illegal activity, and also cannot present a significant risk to public health and safety. So that's already covered. Here, we're also talking, we don't want to use excessive use of plastic, which I never actually thought of, but that is a concern. And we've already kind of agreed that it's the blind leading the blind, and that all these things that were initially talked about were not even based off of anything because there's no standardization of marijuana testing limits throughout different states. That's why I'm very happy that they've implemented that in the OLCC with all of our testing here. You know, with Colorado, just as Amy said as well, they had a second chance and they kept the limits, and I'm talking specifically now about marijuana edibles. At 5 and 50 is what it is here. I don't understand why we would not follow the lead of Colorado at 10 and 100, especially how Washington's doing it. And if we're talking about all the things that have happened, there's been a huge influx of culture in Colorado. This was brand new in the United States. People went there, got a little crazy, and it's on the steady decline now. I agree with education of the public. I think that the public should absolutely be educated, and I believe we should be 10 and 100 milligrams.
Thank you very much.
Thanks.
Donald Kramer, I'm not trying to be rude.
No,
Corey
no, no.
Botter. Okay. Donald Kramer, Corey Botter. Stacy Wagner.
Well, I'm PK,
Tristan
which
Powell. I'll get
is
you-
Kramer.
Okay. I haven't.
That's different, right?
Okay.
Tristan Powell. No. Andy Vixel. Go ahead.
My name is Corey Vodden.
Thank you.
I'm here in behalf of a lot of patients, and I'm also a parent. I have 4 children, ranging from 7 to 15 years old, and all 4 of my children have been raised around this and understand it, and have never once been affected by it, or even had, try to attempt to get at it because of the education. I believe we should really take into consideration of the same on medical as recreational, on limitations on the sizing or concentration limits. There's no reason to go any lower than a gram. Thank you.
Thank you. Andy Vixel, Julie Garado, Laura Rivero. There's Andy. Kathleen Johnson. Go ahead, Andy.
Okay, I just wanted to quickly restate what a couple of people had said, and kind of that we need to differentiate whether we're talking about child safety or adult education. And I think it's really important that we put a really big focus on educating both the adult novice consumers and the child safety consumers.
Oh, thank you. Kathleen, go ahead. Phyllis January.
Good morning, everyone. My name is Kathleen Johnson, and I'm here again on behalf of the Coalition of Local Health Officials who represents all 34 local health departments in Oregon, and that they work to protect the public's health. Oregon's local health departments support a 5 milligram serving size and 10 milligram package size for edibles and drinkable marijuana products. A lower suggested serving size and package size would protect the most vulnerable children, which has been a large topic of conversation here today. And as has been stated, there have been many anecdotal examples, and the CLO would like to strongly encourage the committee to utilize the data and evidence available to determine serving size and dosage, and when scientific evidence is not available, apply the precautionary principle, as Dr. Lewis mentioned, and set the doses at a lower amount. And I think education has been mentioned a lot here, and for those familiar with public health, education is an important component in preventing accidents and unintentional injuries. It's not the catch-all, and so data is strongly encouraged when providing or when making decisions regarding this particular issue. Thank you.
Great, thank you. Phyllis January, Shabad Kalasa, Stacy Marie George. All right. Megan Phillips.
2 weeks on Megan.
Okay. Michael Tuguia? I might have gotten that wrong. Toggle? Sorry.
Pauly. It's okay.
My name is Stacey Marie George. I'd like to thank everybody with the OHA and LLCC in Oregon for allowing me to be here as a medical patient. I'm going to speak in 2 weeks. I would like to request to speak with the other patients. But for retail, I like the idea of a 10 and 100 milligram limit. I do not agree with the limit any lower than that. And actually, I think that even more in patient education or just retail education, there are a lot of people who are unfamiliar with cannabis at all, and it's an undiscovered and untapped, if you want to say, marketplace for retail. And education is key. I have a 9-year-old as well, and I keep medication up where medication belongs. I do not keep vitamins down. Children can get into a locked, child-proof container of vitamins. Has anybody ever seen how easy that is for a child to get into? How many results of research, education, studies are there? Vitamin overdoses in Oregon hospitals. OHSU, how many vitamin overdoses have they had for vitamin D, vitamin C? They're not individually wrapped vitamins. You can open it up, take as many as you want, and kick them. They're not individually wrapped. These are the issues that I have just with the retail side. Patient education, retail education, parent education. There are children. They're your responsibility. A package keeps them out, but your responsibility is saying why you don't need to get into that package. That's where the limits need to happen. work with people instead of against. We can do this together. It really is what it's supposed to be, right? That's why we're all here. Thank you so much for allowing everyone the ability to talk, whether or not we agree with our side. Thank you, emphatically.
Thank you very much. Michael? And then Sally Alworth is next.
Thank you. My name is Michael Colley. I'm a lifetime working resident. I'm a Iraq war veteran, and I'm a patient as well. I deal with veterans throughout the state regularly, especially on dosage. That's a really hard thing for vets. You want to try to get 8 full hours of sleep every night. You're taking a tincture, typically it kicks in really fast, but it wears off really fast as well. So having high dosage is very important. Veterans so we were talking earlier, and you wanted to take the therapeutic value of cannabis. It's inherently therapeutic. If we're using it medically, it's inherently therapeutic for recreation. Now, saying that everybody that wants to use it for therapeutic values has to go through months of processing and talking to their doctor about it, and then paying all these fees to get one try of it at a high dosage, that's really hard. Talk about veterans access. Most veterans don't even go to the doctor to talk about PTSD until 10 years after they separated. I'm lucky. I had a supportive family, and I had people that pushed me towards actually getting help, and I was able to do it in 3 or 4 years. And so now let's talk about dosage really quick. I'm at a stable dose, and I've been at a stable dose for the last 3 years. I take 500 milligrams of THC every night to get 8 hours of sleep. If I take less than that, by even 20 milligrams, it screws me up. So by saying that I can go out and I can buy 1 gram of oil, decarboxylate it myself, and then make my own capsules, it's going to be completely crazy. Can you do the math right now? Like take coconut oil and do that? I don't think you can. It's really hard for me to even do it myself. So I have to test it and retest it and get those things down there. Now if you try to make a medical at 5 milligrams, and that's really hard because every testing facility has it differently. So now if I have something that tests at 6 milligrams from one testing facility, 4 from another, do I have to eliminate that whole thing? So what I'm basically saying is that the limits are silly, and that having excessive limits, is actually a responsible way of doing it, because of capitalism in general. If it doesn't sell, it's not going.
Thank you, Michael.
So thank you.
Sally Alworth, and the next will be Janice Patton, and then Michael Henderson after that.
Good morning, I'm Sally Alworth from Luminous Botanicals. I'm also a member of the Oregon Cannabis Association. Just a couple of quick points. First, I want to support Jeremy's point around tinctures, that it may make more sense to just remove the container size, that as long as a position limit has been set, that could be a large container or small container, but you've controlled for the total access to active cannabinoids. And second, I wanted to offer a clarification. There was some talk at the end on the recreational side that consumers could purchase concentrates and make their own pills. Right now, the way the rules are written, none of those concentrates are for edible use or oral use, and they all have to be marked do not eat. So if the committee really wants to go in that direction, there needs to be some adjustment. And then the last thing I would say is if these rules go into effect as written in April 1, and they're going to be significantly different for July 1, I strongly encourage the OHA to bridge that gap somehow, so that we don't have products completely retooling or going off the market for 3 months, because that will kill a lot of small businesses. Thank you.
Thank you, Sally. The next.
Hello, my name's Janice Patton, and I know you said to keep it recreational retail, but I never give up a chance to fight for my life. I would like to say that please tread lightly when you're limiting amounts, especially where cannabis oil is concerned. I myself take a very huge amount of cannabis oil daily to survive a rare brain disease that I'm fighting. I would much appreciate your consideration on this whenever you are setting these boundaries, these laws. I really appreciate your time today and hearing me out. Thank you.
Thank you. Michael Henderson, Will Johnson, Nick.
Hayashi.
That was another word. Yes, that's all one word. Hayashi. There it is.
And then Adam Vargas? Nobody? Okay. Christy Powell?
2 weeks.
Okay, thank you. Pete Kramer then? Okay. Go ahead, sir.
Yeah, a lot of, it feels like there's no
What's your name,
logic.
please? I'm sorry.
Oh, Adam Vargas.
Thank you. Go ahead.
I'm a patient and I have a rare unknown disorder, autoimmune disorder, which has left me with the skeletal structure of an 85-year-old. I'm 35 years old. It feels like there's no logic here. With alcohol, there's no child-proof cap. There's no limit on the proof you can put in a bottle, or the amount, or the size of the bottle. Kids die from alcohol poisoning from ingesting liquor, and that tastes horrible. And yet, kids still will pound alcohol. It happens. Also, parents, like, are you trying to parent the parents? Like, tell the parents how to parent, because we know how to keep things away from our children. I have 4 children, all under the ages of 10, and they all know about my medicine, and they know that it's yucky, and they're not supposed to take it, and they don't go anywhere near it, and I don't put it somewhere where they can reach it. And and I'm not the only one. It's logic. You just, you worry about the concern and the safety of your child in a million things. I always say that raising children is just keeping them alive before they get out of your house. Because there's a million ways a child can die.
Yeah.
But in regards to dosage, 2,000 milligrams doesn't even do anything to me. It doesn't make me high, and it doesn't get rid of all my pain. I have 0 cartilage in my body. All my bones have been rubbing together since my teens. I have ligament and muscle problems because of this. And, these doses that you're saying are laughable. This is going to create so much waste. I'm also a maker, and if I put my products in all these packages, my package would be this big, and it would be all plastic. And it would cost the same amount for a quarter of the dose that it's going to be, and nobody's going to pay for that. Nobody's going to want that.
Thank you very much. Lindsay Reinhardt, Pete Kramer, great. Lindsay, and then Nikki Gates after that.
Hello, Pete Kramer, a patient of Dr. Lebec, which was the first physician to help the patients get their medical card. It's ridiculous for the prices the patient has to get for his license. But we're talking about regulation or everybody using cannabis. What I heard at the beginning, they weren't going to sell edibles to the regular people. But regular people could need to pay the medicine as well. I believe in what Amy has said in several of her comments during this meeting. With the Mercy Center, I got a television show on Channel 23. I'm a concerned citizen, letting the people, the public know what's happening, what you're trying to pull over us. We're poor people. Thank you. Have a fun time and go fly a kite.
Lindsay, go ahead.
I have 2 points to make. I'm going to go ahead and stick with that recreational extract portion on the 1 gram serving. So I had the privilege of trying a flower over the weekend that was 29.53% THC in a 1 gram portion. That's 290 milligrams for a joint. So having a 250 milligram package for an extract or concentrate makes absolutely no sense when I can acquire a joint stronger than that. Also, I had just found a new favorite beer. It's called Not Your Father's Root Beer. It looks just like root beer. It tastes just like root beer. It's 5.9% alcohol. Guess what my kids don't get into? And guess why they don't? That beer is kept in my fridge, and I told them, this is alcohol, don't touch it. I got you your own root beer. And they listened. That's parent education. We need to stick to parent education. These funds are allocated into education. Let's use those funds for that education instead of making rules on things that fall on the parent. As far as edibles limits goes, that 5 to 50 portion does not fall in line with Colorado or Washington, and it could be set at 10 to 100. And on the topicals, products that are decarboxylated can interact. Products that are not decarboxylated will not interact. 2% is a very low threshold and not therapeutic enough for many people, including recreational consumers. Lastly, tinctures come in alcohol and glycerin forms. They often come in 2 to 4 ounce bottles, and those limits need to be set higher. Thank you.
Thank you.
Yay!
I've got a couple people who drove far. So Charles Weller from Eugene, and then Anna Kahn. You both identified that you guys drove pretty far. So.
I know everybody's.
And we're going to get to everybody. Don't worry.
You know, everybody doesn't have a lot of time. So my name is Charles Weller. I'm a critical source. We do CO2 cannabis oil extraction in Eugene, Oregon. I'm also a member of the Emerald Trade Alliance on the administrative team and the Oregon Extractors Association. I was on the Oregon Liquors Control Commission Extract Processor Rules Advisory Committee. I just want to make a couple quick points. First of all, I think that stands out for itself. Another thing, you're talking about roughly a gram of extract in one of these containers. You're cutting it down to about 250 milligrams of THC. Such a tiny amount that trying to get it out of the container alone, with the consistency, you're going to waste so much that it's not even feasible. So you need to look at 1,000 milligram level. The most important point here is if you're cutting it back to 250 milligrams, with the cost of packaging, the black market, people are just going to go buy it off the black market. And then we have no protection for our kids. So thank you very much.
Linda Alvarado, Kara Burnett? Okay. And then Dale Peterdorf. Go ahead.
Hi, my name is Anna. I am an activist and a parent of a child with traumatic brain injury. She has been on cannabis for 3 years, and she takes an extremely high dose for her seizures. And I am also a single mother of 4 children. A 14-year-old teenage daughter, a 6-year-old, and a 4-year-old. And the 6 and 4-year-old asked me about regular candy. Does this have your medicine in it? You know, it's education. You know, even my 14-year-old had to learn the hard way. I've had to learn the hard way. It's really, the key is to educate you guys, as parents who are experiencing it firsthand. Reach out to us. I'll teach you everything I know about giving my kid cannabis every day. And she doesn't have seizures anymore, and she has half a brain. So I just really think that opening all of our minds is really important.
Thank you. So, Mark Fessler, also. I've called your name. Go ahead and start getting ready to come up. Carla Kay, Daryl Hudson. Go ahead, sir.
My name is Dale Petersdorf.
Great.
And I'm a grower from Salem. And all I really have to say is that you cannot legislate risk out of existence without taking away people's right to choose. That's all I have to say. Thank you.
Good morning. My name is Carla Kay. I'm with Skunk Farm Research, also a member of Oregon Cannabis Extractors Association. And I just have a couple of things to say. First of all, we've talked about this not being a child-proof container, but we also don't have individual packaging servings in it. So I think that we should, whatever we do with cannabis, we need to follow through with everything that we've already done with things that we control. When I go to the liquor store to buy this, they have infused chocolates on the counter. Those are not in child-proof containers either. And they're not in single-serving sealed containers. Thank you. It's beautiful.
Daryl Hudson, Riot Schnecker, sorry. Michael
Calling? Michael Calling?
I spoke out there, sorry.
Okay, and this, Galal, Megan Graham. So let's keep calling names. Terrence McDaniel. Carrie Strawberry?
Stanberry.
Stanberry. I probably, it looks like a W, it does.
I'm Megan Graham with Gem Farms. Rec or medical, I want to say a brief thing about industrial hemp. My lawyer, Courtney Moran, sent me a section about industrial hemp products. A dispensary may only accept the transfer of and may only transfer a product that contains THC or CBD that is derived from marijuana. I'm here, the OHA should not have an outright prohibition on industrial hemp products. The OHA should allow cardholders to transfer industrial hemp products into medical dispensaries. I think it should be in rec dispensaries as well. To make my dispensary clients feel safer, I still take my product to testing, labeling, and packaging very seriously and follow the guidelines as outlined in the OMP rules and regs, even though as an industrial hemp product, I don't necessarily have to. But I want to make sure that my patients and even the rec users have all the testing information that they would want. And so I comply with those rules so that I can get it to the market that best understands my product. Even though I could have it in Bi-Mart or natural grocers, the marijuana industry is the one that understands my CBD infused industrial hemp products. The two main products that I have, Rub It In topical and CBD agave sticks, help a lot of patients and rec users. A lot of people have come out of the closet and for rec using because they don't want to get their medical cards and find these products useful. They help them sleep, they help the pain. It's not just medical, it's also the recreation. So please don't take that away from them. I'm following the same rules as the cannabis users. Why are you proposing industrial hemp CBD infused products be left out of the dispensaries?
Thank you very much. If I've called your name, please go ahead and come up if you want to give a public comment. Peter Rose, Michael W. Fox, Christine Smith.
Yeah.
Okay. David Bowles, and then Michelle Suppian.
Hi there, my name is Christine Smith, and I'm the owner of Grand Chocolate. And I'll be back next week, or in a couple weeks, to discuss the patient limit. But one thing I just really, I think I recognize a lot of these other manufacturers in the room. And we're under tremendous pressure right now with our packaging requirements. It's a good 5-6 weeks out from the time that I know I do, from the time that I send in my packaging to get them produced and able to get them even packaged and on the market. So we're reaching quickly, very quickly, reaching a point where wherever we end up on this, we need to have a decision, or come April 1st, we're really in a hard spot. I mean, come March 1st, we need to be putting this new product on shelves. And we're, sitting here with our hands tied. So I just really implore your assistance in one way or the other. I strongly stand behind the 10 milligrams, 100 milligrams on the rec side, and I think there's another discussion for the patients. But yeah, if we could really get some direction on that, I think it's significant cost and input for us.
Thank you. And then after Michelle, is there anybody else whose name I didn't call? Okay, let's go ahead and line up and we'll. How many of those people are there? Raise your hand. All right. 3 or 4. All right, we gotta keep going. Go ahead.
My name is Michelle Suppian Chilton. I have multiple medical issues. Oregon's own public health website, Prevention Wellness, states that Oregon has one of the highest rates of prescription opioid misuse in the nation. In Oregon, more drug poisoning deaths involve prescription opioids than any other type of drug, including alcohol, methamphetamines, heroin, and cocaine. Please notice there is no mention of marijuana because there is no reason. It makes no sense to treat weed as if it were equal to or worse than alcohol, methamphetamines, heroin, and cocaine, since there is no science to support your position. Your mistreatment of medical marijuana and OMMP patients by treating weed as if it were worse than any of the above referenced drugs is untenable. This is, note that alcohol is considered as bad as heroin on your own website. This is far from any such science regarding marijuana. Thus, it is wholly antithetical to the purpose of the OLCC and OHA's mandate to protect public and patients while allowing easy, reasonable, and affordable access to marijuana. Like myself, many patients who find pain relief, diet needs, and sleep assistance through marijuana are quickly priced out of access by OLCC and the OHA rules and regulations. For many of us, edible marijuana is the preferred manner of intake. Edibles have no lung, gum, or tooth damage.
We're over time. Thank you.
I'm going to try to make sure that I'm not over time. There's so much that I would like to be able to say to you guys right now, and this time I'm going to try not to flip out on you guys, all right? First of all, I am Marlon Starr of Mean Green Cream. Not a single one of you guys have ever come to me and asked me what the industry thinks. You have never ever come to me and asked me what my safety and precautions are. I'm here to tell you that I'm the first person that does not want to put a tainted product on the market. I'm here to tell you that you guys first need to be concentrating is on the testing facilities. If I cannot guarantee that I can walk into a testing facility and get accurate results, how am I supposed to put a safe product on the market? Pesticides, herbicides, molds, and solvents all transdermally go through the skin at a very regular basis and very quickly. If you want to talk about the poison, let's talk about not doing testing properly in order so that I can put a proper thing on the market. Trista from Empower over here is also a leader in the market on topicals. Nobody has talked to her. If you actually want to do regulation that is reasonable, that the people will follow and not go to the black market, you better start talking to the people that count. You better start talking to the people that are actually in the industry. People like myself that have been putting 8 years of research and product testing in people's hands to ensure that I am supporting the immune system and people's health. Thank you.
I'm a patient caregiver and grower, and I just want to remind everyone
By the way, I
that
have 20 more seconds.
there were 130, there is pretty much everything else on the market is more toxic than marijuana is, and it seems that even though there's been unregulated sales in every state pretty much, we still haven't had that many people overdosing from it, and it looks like every other, this is the Washington Post, November 2014, basically everything else has brought people into the emergency room, but it's almost zero for marijuana. Ibuprofen, diaper cream. In fact, diaper cream is 136 times more likely to be poisoning a child than marijuana. So please let's not do any limits to medical marijuana. I understand that we will need to have correct packaging, and I think you all are on top of that. So yeah, thank you for hearing me out.
Yeah. All right, so we have now gone through everyone who's signed up. Sir, you're sitting
No, we have Tristan from Empower.
Oh, okay, you're back. So you signed up earlier.
Your conference is ending now.
So we are going to dedicate over an hour at the meeting on the 25th to public comment. We will go through. You're there, and 2 more people up here. There's 3 people. What? All right. Well.
Just start talking, Tristan.
Go ahead, start.
My name is Clay Pierce. I have to reiterate what Marlon says. We need testing more than we need anything else. This is hysteria. No one has ever, in the history of eternity of man and civilization, has ever died from marijuana alone. Period. This is insanity. You guys are gonna drive the little people out of the market by all this money grabbing. The big industry is the only one's gonna be able to do anything. They're gonna ruin it for everybody by destroying the cannabis plant itself. This is craziness.
Margaret Luke, will you come here, please? Go ahead.
My name is Trista Oracle. My company is Empower Body Care. I make topical products for relief of pain, inflammation, and skin trauma. I'm here today to discuss or to bring to your attention that topicals are safe and effective medicine for, or maybe not medicine, direct market, but safe and effective for everyone to use. Unless it's a product that's designed to be transdermal, there is no way that this product is going to get someone high. I'm going to be submitting it in written testimonies, studies, and peer-reviewed articles that indicate such. Every topical maker, well, not everybody, okay. Here's the deal. If we regulate topical applications to the point where they can't be strong enough for people to actually get pain-relieving effects localized, because they are only localized, then we're going to be creating a system where people don't get the pain relief they need. These products are shown to be way more effective than products like Bengay. Those products aren't regulated in the same way. Natural products that are pain relievers, if we follow all of the current natural product labeling rules, I think that is plenty. Up in Washington, there's a 3% rule, or 0.3% rule, that allows THC-containing products on the mainstream market. I would love to see that happen, but at this point, please don't limit the topical concentrations.
Thank you. Go ahead. So Katrina and Jerry are going to continue to take notes from the public comment, and we will receive all of them. And in 2 weeks, when we meet, if medical patients who take high doses are comfortable, when you provide public comment, it would be helpful for us if you would tell us the amount of high-dose THC that you take, either in a dose or daily. And again, only if you're comfortable sharing that with us. That would be helpful as we start to get right. Okay, go ahead, Lucas. Thank you.
My name is Lucas Littlefield, and like Trista, I own a topical company. I also am a consultant in the industry, and the reason I bring that up is when I work with folks in the industry that have business, one of the things that I've talked about is, let's say you want to start a marijuana brownie business. A good way to approach that with a lot of these regulations yet to be determined is to start a brownie business. You can follow FDA regulation and packaging, you can follow rules as far as ingredient listings and things like that go. And then after you have that research and everything put together, you can then put on the marijuana frosting, if you will, and you know, fit into those regulatory statutes. So the company that I own is called Nabalm, Natural Effective Balm, and it came from a marijuana topical. Before regulation testing, dispensaries, it was being made, given out to patients. We had a batch that was made one day without marijuana. It was given out to patients, labeled, packaged, and distributed. I found out later that that batch didn't have marijuana in it, but we had some feedback from our patient population. Some of them had said that whatever we did, whatever we changed the product, it drastically changed it. And a lot of folks said that it didn't. The reason that I bring this up is that with topicals, there are essential oils that have therapeutic value and effect, and some of the FDA doesn't approve, so you can't claim that it does not do something. I think at this point, without having all of the research present and available to us to what cannabinoids do, whether it be THC, CBD, or the other 12 classes, we don't know yet. So if we can put on some kind of a cautionary statement as far as, you know, this product is unregulated by the FDA, we don't know what it does. I think that would be the most truthful statements we could make now, but when we're jumping around this dance of limitation and dosing and whatnot, we don't know what a dose is yet. We don't. We have no idea. We're setting arbitrary numbers in other states. We're saying milligrams, grams, and all these things. We actually don't know yet. So whether someone is on the medical side, whether they have their card or not, and they need to use a higher amount, or they're on the recreational side and they want to get really, really medicated, we just don't know yet.
Thank you very much. And I'm sorry, the other folks had to go to a meeting, but that doesn't mean that your comments aren't really important to us. And I was going to ask if people could please stay quiet so that we're respectful, even if people haven't presented yet. We want to respect everyone. So again, who else? We've gone through the list of people who signed up. I know these two gentlemen from Roseburg. Why don't you two come and speak, and then again, everybody will get an opportunity. And as was already said, if you haven't had but feel strongly, please submit things in writing. We do take all of that into consideration as well. So go ahead and please introduce yourselves. Speak up, please.
My name is William. It's my associate David. And
excuse me for a sec. Could we shut the doors just so folks can? Again, I'm trying to be respectful of everyone who's talking. Thank you. Go ahead.
First of all, I'd like to say that there should be a line between medical and recreational. And as recreational goes, you know, the FDA approves drugs, you know, with harmful side effects and you know, cause severe problems, you know, with that. And they have packaging. You know, I can go to the doctor and get a 3-month supply of a concentrated elixir, you know, that can, you know, physically put me in a coma if I was to drink the whole bottle, you know, at one sitting, you know, and you know, you can get your, you know, concentrated 151 rum, or you can go get, you know, the same size bottle is in a 5% alcohol wine, you know. So it needs to be kind of segregated depending on you know, whether you're doing recreational or medical, because each patient, you know, each person has, you know, I'm a little guy, you know, I might, you know, take, you know, X amount of this consumption when this guy twice my size might need more.
Or less.
Or less, you know, he might take one sip of that alcohol and just go loony, and I can sit here and drink a fifth of 151 and drive home, you know. But I hope not. Yeah, I hope not. You know, but just as a, you know, as a reference point, you know.
Thank you.
I just want to say thank you because you guys did hear us last time about talking about the difference between CBD and THC. And I also wanted to say that, no offense to anybody, but a lot of people that are making these rules don't know.
Absolutely.
Say for instance, when you go to fix your car, you ask a mechanic, you don't ask a dentist. You know, when you want information on what's wrong with the car. A lot of us have actually paid for our knowledge with our freedom. We've been to jail. We've, you know, just for growing a plant or, you know, providing medicine. And we have years of knowledge, and we're just now coming out of the hiding. You guys should take advantage of that, ask us some questions, and we can help you set these standards. And, you know, we know these things. Like a lot of these things you guys are wondering, we already know. Like, for instance, they were talking about CBD. CBD, for instance, if kids take as much CBD as they want, they're not going to get high. They're not going to get high at all. And that could come from a bud. And say, for instance, in Colorado, they can grow under 3% THC. They can grow a whole hemp field, and they call it hemp, even though it's not hemp, as long as it's under 3% THC. We can only grow 6 plants, but if your patient wants CBD, they got to take away 3 of their plants, so they have to take away half of their pain medication just so they can have a little bit of CBD, and then they're out pain medication for the rest of the cycle. So we do want you to definitely, you know, notice the difference between CBD and THC. Also, just recognize that the research that you guys are basing all this off of is coming from NIDA, and their highest THC is like 10%. And they don't use any other genetics. They use just the genetics from the States and don't introduce anything else. Their highest CBD is like 11% or 15%. And it's all, I got 25% in my backyard, you know? Like, the information you guys have isn't complete.
Thank you.
I think the biggest thing is the information on the product, you know, needs to be there to aware the public whether the intended usage and concentrated dosage, you know.
Great.
So the information just needs to be there.
Okay. Thank you. Who else would like to? I see a couple of people standing up. Go ahead, and please introduce yourself.
Hello, my name is Dan Houston. I do own a laboratory, and this is actually mainly for everybody out here. I hear a lot about laboratories, a lot about the test results. I think it starts with us that are trying to find a laboratory. I highly recommend you inspect a laboratory, walk through the laboratory. If they won't let you walk through the laboratory and inspect them, maybe they're not a good laboratory. So it starts here. with trying to get the laboratories that are producing good, accurate results. Find them, figure it out, read the news articles. Oregonian, Willamette Week, pick up any one of them. You'll find articles on laboratories. Starts with you guys.
Thank you very much. Go ahead, if there are a couple of folks, you're welcome to sit down.
Cody Wheeler, Wampool Extracts. I'd like to say that individual dosage needs to be an individual choice, and also that recreational marijuana is preventative medicine. Thank you.
Okay. Thank you. Go ahead. Please introduce yourself.
Sure. I'm Iley Powell. I'm a patient and a bud tender at Foster and Gleason Buds. And I just really wanted to point out that people in the recreational market are very much seeking CBD products that have very little THC, to the point where we cannot keep them on the shelves. And please do not in any way think that everyone just wants to get stoned. They don't want to be out. They want to be out of their senses. People are really seeking medicine. They just didn't want to deal with the bureaucracy that's involved with getting an OMMP card. These people really want it from a medicinal standpoint, and they really want to hear this information from me of how do I use this medicine to benefit my life and to get a better quality of it because it's medicine. Thank you.
Okay, thank you. Next, please.
My name is Stacey Whitmer, and I am a patient. I am 32 years old, and I have stage 4 breast cancer. This is the second time in my life that I've had cancer. I use a severe high concentrated dose of CBD every day. I use about a 10 to 20 milligram dose every 2 to 3 hours. I cannot imagine if we put a limit and an increased price on the recreational side. I already can't afford my meds. I already can't afford my food. Like, if you took more of it away from me, I don't know what I could do. So I really appreciate if the concentrations level increase and the prices stay low, because I would die. It's pretty much bottom line for me.
So thank you, and don't forget, the medicinal discussion is going to happen 2 weeks from now. So just want to be clear that, you know, a lot of folks have talked about medical as well as the retail, and I do understand that there's some crossover between that, but I would suggest that you also make comments next week. Yes, thank you.
Hi, my name is Severing LaPlante, and I'm CEO of LB's Edibles, and I'd like to kind of just comment towards the medical versus recreation discussion that we're having here, and bring up the point that there's a really large barrier to people entering the medical system due to healthcare situations and insurance coverages and whatnot, that a lot of people can't even talk to their physicians about medical marijuana. So there is a large percentage of the recreation market that is very much looking forward to the ability to take advantage of the medical products that are out there. And I think we do a real disservice if we look at both markets as being really exclusive of each other and don't recognize the institutional overlap that's just caused by the healthcare system. Thank you.
Thank you. Are there others interested in talking?
Hi, my name is Amy Mellon. I'm a patient. Cannabis saved my life. 8 months ago, I was in bed. I've worked for 15 years. I have had so many people read my story in the last 2 months that are coming to me wanting to live again. My kids have me back again. I've taken thousands of pills over 10 years, and all it was a car accident. I call it the innocent addiction. But because there's people, like he said, that can't go to their doctors and they can't be open with them, they're suffering. And it's not just people that are hurting, it's addicts. We have a huge problem. Please don't limit these concentrates. Let us live again. Let other people live again. I would be at home in bed. My 17 and 18-year-old girls thank cannabis because their mama is alive and out of bed today.
Thank you. Yes, please.
My name is Michael Smokey Schneider, and I'm with Original Extracts. And I just want to say that, you know, when I voted to legalize marijuana, I voted to legalize marijuana. Not like this quantity's illegal, this quantity's legal. When you have this much, it's illegal. No, we voted to legalize marijuana. We said we want to legalize marijuana as a people, as the majority of the people of the state of Oregon. And those are the rules we want.
Okay.
Yay!
Hi, I'm Courtney Moran, and I'm here just to say that I really appreciate all the time that you guys are putting in here, but what's happening is overregulation for people's medicine. It's a program that has been working for 17 years. There's no need for this overregulation now. Especially, I mean, you're threatening basically to take away people's medicine, whether it's derived from marijuana or if it's CBD derived from industrial hemp, and that really needs to be considered. And I want to give the rest of my testimony time to this kind woman. She prepared testimony for you today, and she was rudely cut off earlier, so I want to give her time to him.
Okay, and again, I would ask you to come and testify in a couple of weeks when we'll be talking about the medicinal market. We're really focused right now on retail, and I did hear the comments about the overlap. Go ahead.
Michelle Suffian again. Put this a little closer, not that I need it. I'd like to finish what I said, and I thank her very much. Considering the current state of Oregon's push against smoking as advertised on billboards all over town, that 1 hour of hookah equals 100 cigarettes, so either the Multnomah County wants to reduce smoking or wants to promote smoking by not allowing high enough dose medibles to be available. So which is it? You want smoking, or do you want no edibles, or you want no smoking, you want no choices? As for the children's protection, no actual drug is required to be a lower dose. Only a disclaimer on the label against leaving medibles. And it makes, for medical options, many OMMP users require higher dosages to attain relief than the OLCC or OHA are allowing, requiring us to buy more packages for more money than that's necessary. This must stop. Prices can be reduced by reducing licensure fees. To that, no higher than alcohol outlets. I do not have to pay an additional annual $200 or $250 at Walgreens before I can even obtain my medications. Neither should I have to overspend or expand my budget just to afford edible medical marijuana in appropriate larger than recreational doses. By your dosage schema, I would have to buy so much for an everyday usage. It would be prohibitive. Prices can, please update your attitudes and rules about marijuana edibles to reflect the present realities, patient finances, and science. The world is not flat, and medical edible marijuana is not a killer drug. It is not an opioid. It's not near an opioid. Unlike alcohol, which can be purchased freely in any and easily off any liquor store shelf. Marijuana edibles must be allowed to come in higher quantity THC and or CBD doses without causing bakers and confectioners outrageous licensure fees or taxes. Please be rational. Thank you.
Okay, and again, I would suggest that you come in. Okay, all right. So you can submit any comments that you'd like also in writing. So is there anybody else in the audience, and again, I apologize that folks had to leave, but anybody else who wants to comment today? Okay, so do it quickly because we are 20 minutes over, but we do want to make sure that people have a chance.
My name is Micah, and I'm a patient, but there's just one quick point I wanted to make is I pay a lot of money every year so I can be a patient, and it's really, really hard to afford it just so that I can actually get affordable medicine versus going to a dispensary and getting it, which I'd much rather do because I don't need that much. I just need enough. And if I have to go to a dispensary and get 20 packages for, one dose, it doesn't make a lot of sense. It's not feasible financially. And so it'd be a lot better if people could not have to get their cards if they can't afford it. Or maybe you guys could bring those prices down.
I can't speak for the program, but I think there's a sliding scale for card
There
holders.
is, and there's a sliding scale if you get food stamps and stuff, which I don't, so I end up almost $400 a year.
All right, thank you. And again, please come in 2 weeks when we're talking about the medical part. Anybody else in the audience? All right, well, thanks everyone who stayed in the room, and again, we very much appreciate the public input to that. Thank you.
Thank you, Channel 23.